Good evening, friends. I'm Professor Sheila Maitra, Professor of Intensive Care at the Tata Memorial Hospital, and I'm delighted to welcome all of you to this session on hemodynamic monitoring in shock. And this is going to be a focus on COVID-19. And I'd like to welcome all our international and national speakers today and all of you. Really difficult times we're going through, especially in India. And I'm really grateful to all of you for taking this time out and coming here for this webinar. A lot of webinars and sessions have happened on respiratory management of COVID-19. And as you know, a lot of these patients, sometimes later, sometimes early, present in shock or hemodynamic instability. Pulmonary embolism is common. We also have viral myocarditis. So I thought it would be very interesting to have a focus on the hemodynamic aspects of COVID-19. So while these are going to be general talks, we will be focusing on COVID-19. So we are very fortunate to have the doyens of hemodynamic monitoring with us. And I'm very grateful to Professor Michael Pinsky, who's from Pittsburgh, USA, Professor Jean-Louis Taboul from Paris, France, Professor Daniel De Becker, who is from Belgium, and Professor Thomas Sherin, who is from the Netherlands. We also have our very own Dr. Atul Kulkarni, who is from my department at the Tata Memorial Hospital, Dr. Deepak Govil, who is from Medanta, the Medicity, and Dr. Srinivas, who is a consultant intensivist at Hyderabad, and my boss and colleague, Dr. Divatia, who's going to just be joining us shortly, Dr. J.V. Divatia, who is also going to steer the discussion. So without any delay, I move on to the proceedings. What we'll have is a series of 4 talks first, and these are going to be just an overview of hemodynamic monitoring, and I've requested the speakers to focus a bit on COVID. And following that, we have a very interesting interactive case discussion. So I would like to introduce our first speaker, Professor Michael Pinsky from UPMC, United States. Professor Pinsky really needs no introduction. I was just going through his CV. I think we will have to go through the whole session if I just have to read out his CV. But he is a professor of bioengineering, of cardiovascular dynamics, of critical care, of anesthesiology, you name it, and he's an expert in all. For me, he is synonymous with hemodynamic monitoring. I would call him really the father of hemodynamic monitoring. And if you've attended the course at Brussels, along with the others on this panel, he does an excellent session on hemodynamic monitoring every year. So without any delay, I'd like to invite Professor Michael Pinsky, and he's going to give us an overview and talk about the basic principles of hemodynamic monitoring. Over to you, Professor Pinsky.
What I'm going to talk about is the strategies to monitor patients. These are my conflicts of interest, though they're all related to hemodynamic monitoring. And what I'm going to talk about today is a fundamental truth, and therefore none of these things are relevant. When we consider managing our patients that are critically ill, hemodynamic monitoring is just part of an ongoing assessment of physiologic and functional status of the patient. It should not be considered separate from physical exams or observation. Importantly, though, what we do with hemodynamic monitoring is very much context specific. If it's pre-op, emergency department, OR, ICU, or on the floor. And the time frame is important too. Are you trying to do something acutely, as in the initial resuscitation, or once there's stable maintenance? And when we talk about monitoring, it's often asked, are these tools or are they toys? Because we can measure almost anything. And though I strongly believe that the one who dies with the most toys wins, I don't think that we should pay for it with our hospital money or inflict it on patients. Importantly, there is no monitoring device, no matter how insightful its information, that will improve patient outcomes, unless coupled to a treatment, which itself improves outcome. And here we're talking about circulatory shock. And for that, we know that if we can resuscitate a patient appropriately and early, we can prevent end-organ dysfunction. There are different environments for which we monitor, and they demand different rules. In the emergency department, we need rapid, minimally invasive with high sensitivity. We don't want to miss anything. And we want to do this for triage and trends and running protocols. Whereas in the operating room, we need to be extremely accurate. Invasiveness is not an issue, but here we need high specificity. We need to know exactly. There has to be close titration and zero tolerance of any complications. For us in the ICU, it's somewhere between the two. In a non-ICU on the floor, it's basically has to be minimally invasive and to the extent possible untethered so the patient can be ambulatory. If we look at the geography of different spots, whether we're in the OR, ICU, emergency room, you can have levels of severity of really intense monitoring or lack of monitoring, and you can have minimally invasive or specialized care such as echocardiography. And if I were to overlay on this my personal opinion of how this geography would look, you can see that the actual structures for monitoring will be different elsewhere. So one has to be personalized and specific. So the mantra of the best you can do is you want to be continuous, non-invasive if possible, and metabolic. Because at the end of the day, what you care about is the etiology of disease and tissue wellness. Okay. So my approach has always been to ramp up monitoring. Intermittent non-invasive is done with traditional vital signs. You can do echo when you admit the patient, look at a chest x-ray, and those are very good initial screening tools. One also has the advantage of continuous monitoring of SpO2, arterial pressure waveform from the pleth, and cardiac output. If you wanted to measure them, there are devices that do that. Intermittent measurements with the central venous catheter or transesophageal echo are very important. And then finally, the continuous measurements with arterial, central venous, and PA catheters. And I still believe in PA catheters, but only in very specific patient populations. So let's talk about the arterial pressure. The baroreceptors defend arterial pressure over a wide range of flows. Thus, hypotension is always pathological. B2B variations in pulse pressure, as Professor Taboul described to you, rather reflect changes in stroke volume, and they are more relevant relative to flow and venous fluid responsiveness than they are cardiac output. So hypotension, if you're treating it in your patient, is a medical emergency. You do not walk to the bedside, you run. The normal autonomic tone allows for blood flow distribution, and hypotension must be associated with tissue hypoperfusion, and the other name for tissue hypoperfusion is shock. We therefore show from several studies that we target a mean arterial pressure over 65, for which we would put in an indwelling arterial catheter and then assess flow. What are the causes of circulatory insufficiency? And COVID is a good example of it. There can be decreased cardiac output, decreased circulating blood volume, and decreased vasomotor tone. In COVID, we can have cardiomyopathies. We can have some degree of decreased circulating blood volume, but that doesn't seem to be the case very much. It's primarily a decrease in vasomotor tone. The goals of resuscitation are very straightforward. You initially target a blood pressure because without a blood pressure, you can't have blood flow. And the methods of resuscitation include intravascular volume replacement, which will be discussed in the next lecture, vasopressor therapy, and inotropic support. And then finally, you look at the response to therapy. It is absolutely ludicrous to give every single patient the exact same treatment and assume that they'll all respond in the same way. You need to target precise therapy, and that's what the hemodynamic monitoring is aimed at. And then we have to figure out the maintenance of levels of support, because excessive resuscitation or excessive levels of vasopressors for a long time increases mortality. So there are certain physiologic truths. There is no such thing as a normal cardiac output. Cardiac output is either adequate to meet the metabolic demands of the body or inadequate. And since the cardiac output can vary significantly, absolute values are only useful if there's zero, which means it's pretty bad. Otherwise, knowing a cardiac output independent of resuscitation and treatments doesn't tell you anything. What you really care about is its response to resuscitation efforts. Okay. Central venous pressure is also very important. People measure it and they think they're looking at volume status. There are certain truths here too. Your CVP right now is the same as my CVP, and if we add up everyone's CVP, it'll be the same number, 0. When you lie down, it may become 2 or 3, but if your CVP is elevated, you're sick. I don't know what it is. It could be right ventricular failure, left ventricular failure, pulmonary hypertension, hyperinflation, excessive volume status. but whatever it is, it's bad. So central venous pressure is only elevated in disease. Absolute values are not accurate in estimating right or left ventricular filling or volume status. CVP rises, though, with increases in fluid administration as a stopping rule and means that you need to reassess the patient because it represents more than anything else right ventricular status. Why is this important? Bellamy described in the operating room with postoperative complications that if you under-resuscitate or you over-resuscitate, you get complications. Well, in the ICU, the patients come in with complications, and they have a much tighter need for fluid resuscitation that gives too much or too little will cause significant mortality. Thus, we have to be very precise when giving fluids, and that's what Professor Vincent is going to talk about, using monitoring to determine volume responsiveness and then who needs the fluids. So in surviving sepsis guidelines that came out just last year in terms of patient therapy, since we know that there is significantly less endothelial leak with loss of fluid, it's better to give a more conservative over liberal fluid therapy because the concern also is the acute respiratory distress syndrome. They recommend the use of crystalloids over colloids and balanced salt solutions such as Ringer's lactate, which is my favorite, over normal saline, and use dynamic parameters such as pulse pressure and stroke volume variation, skin temperature, capillary refill time, and or lactate as necessary. So this is COVID. The reality is the management should follow the following priorities: pressure, flow, function. Get the pressure up first, then get blood flow up to a level that you have normal function of the tissues. Okay? So I have a list of things which I published, I guess it was around 15 years ago in Chest. It was called Dr. Pinsky's Hemodynamic Truths. They're not very important, but they're true. One, tachycardia is never a good thing. If your patient is otherwise stable, but they're tachycardic, they're in trouble, they're in stress. Hypotension is always pathological. There is no such thing as therapeutic shock. There is no normal cardiac output. It's either adequate or inadequate to meet the metabolic demands of the body, and those can vary by 400% in 1 minute. CVP is only elevated in disease. And in the context of fluid resuscitation, peripheral edema is of cosmetic concern. So in summary, one size does not fit all. Ramp up as instability or risks increases in terms of the level of different monitors that monitor different things and the level of invasiveness, because with increasing invasiveness, we tend to get more accuracy of the measures. But to do this properly, it requires a good understanding of the pathophysiologic underpinnings of the cardiovascular sufficiency, which is profoundly important and we often forget about, and insufficiency, so that on the fly we can diagnose, treat, and follow our response to therapy. And with that introduction to this conference, I want to thank the organizers for inviting me, and I'm looking forward to seeing the rest of the talks.
Thank you very much, Professor Pinsky, for giving that wonderful overview on the principles of hemodynamic monitoring. We now move on to the next speaker, Professor Jean-Louis Teboul. I'm really happy to introduce Professor Teboul. He is the Professor of Therapeutics and Critical Care Medicine at the Université Saclay Hospital in Paris, France. He's also the head of the Medical Intensive Care Unit at the Bicêtre University Hospital in Paris. He's the editor of the Annals of Intensive Care. He's the treasurer of the ASICM, over 1,000 invited lectures and several publications. And his area of interest, of course, as you all know, he's a doyen of fluid responsiveness, and he's got several publications related to that, to his credit. So without any delay, I invite Professor Jean-Louis Teboul to speak to us about fluid responsiveness.
So first of all, I would like to thank you for this invitation to participate in this webinar. And I am very honored to participate. I would like also to express my best friendly regards to my Indian colleagues in this context of COVID-19 pandemic. I know you have to face a very terrible wave, and I share your feelings, because also in Europe, in France in particular, we have also to face a third wave. So again, I want to express my solidarity regards. So my talk about fluid responsiveness, I will try to focus on COVID-19, of course. My conflicts of interest are on this slide. I would just want to define fluid responsiveness, which is the capacity of the heart to significantly increase its stroke volume or its cardiac output in response to a volume challenge. The question is, why do we frequently need to assess fluid responsiveness after initial resuscitation in patients with shock? First, because not all patients, even in shock, are fluid responsive. I like to show this study we performed with Frédéric Micha in the past. We pulled all the studies that at that time addressed the issue of fluid responsiveness, and we had the surprise at that time to see that only 52% of patients increase their cardiac output in response to fluid administration, meaning that 48% did not. Another interesting concept is that fluid responsiveness is a dynamic phenomenon, so we need to reassess it frequently. And this is well illustrated by this study, the Andromeda shock study. You know, this study comparing two strategies, one based on CRT, capillary time, and one based on lactate decrease in patients with septic shock at the initial phase of septic shock. This is a study coming from South America, multi-center randomized controlled trial. And in this study, fluid responsiveness was assessed in 82% of patients at the beginning, at the time of inclusion. Patients already received fluids before inclusion. Anyway, 70% were fluid responders at that time, at age 0. And after age 2, age 4, age 6, and age 8, you can see that the rate of fluid responsive patients was decreasing until 4%. So again, it confirms that fluid responsiveness is a dynamic phenomenon. We also know that fluid infusion in non-responders is risky for obvious reasons. We know that fluid overload is generally harmful. This is illustrated by so many studies now. And we have this first study by Jean-Louis Vincent and co-workers, the SOAP study, showing that positive cumulative fluid balance was an independent factor associated with mortality. And now we have a lot of studies confirming these results. And also we know now that the use of fluid responsiveness test is associated with improved outcome. And this is well illustrated by this study coming from Argentina and recently published in Annals of Intensive Care. And as you can see, the use of dynamic tests of fluid responsiveness in a large cohort of patients was a factor which was independently associated with survival in this study. So now, how should we assess fluid responsiveness after initial resuscitation? Now, all the international societies recommend using dynamic over static variables to predict fluid responsiveness. And what is a dynamic variable? If we refer to the physiology and the Frank-Starling mechanism, Frank-Starling curves in a normal heart, Frank-Starling curve in a failing heart, preload responsiveness is this condition where you increase preload and you can have an increase in stroke volume. And how to define dynamic variable or test? This is something which quantifies the slope of this curve at the time you decide to give a treatment to your patient. And we have two categories of dynamic indices or tests: heart-lung interaction indices and passive leg raising test. Heart-lung interaction indices are doable only in patients with mechanical ventilation, and the idea behind is that the more the cardiac output or the stroke volume changes with mechanical ventilation, the more likely the patient is preload responsive. And the most popular indices are those which are related to the respiratory variation of stroke volume, namely pulse pressure variation or stroke volume variation. Briefly, if you have a high PPV, pulse pressure variation, this condition is generally associated with preload responsiveness, and you can assume that the patient will respond to fluid administration in terms of increasing cardiac output if you give fluid. If the patient has a low PPV, low pulse pressure variation, this is generally associated with preload unresponsiveness, and if by mistake you give fluid to this patient, the patient would not respond to fluid administration. This is one of the first studies, or maybe the first study, looking at pulse pressure variation. This is a study we did in our unit with Faik Misha, also Michael Pinsky was co-author, and we showed that PPV was the best predictor, better than CVP and PUP, to predict fluid responsiveness in patients with septic shock in terms of sensitivity and specificity. Of course, we have many limitations in the ICU to use pulse pressure variation, but also stroke volume variation and other heart-lung intorsion indices. And this is why other tests have been proposed, and one of them is a tidal volume challenge. And we know that in patients with low tidal volume ventilation, there are some false negative cases. And this is well illustrated by this study coming from France, showing that many responders, patients who respond to fluid administration, had a low PPV before fluid administration due to a low sensitivity of PPV to predict fluid responsiveness in this situation. And this is why with Sheila Mehrotra, Dr. Divatia, Dr. Kulkarni, and others in Mumbai, we propose another test which consists in increasing tidal volume from 6 to 8 ml per kilogram for 1 minute only, and to look at the changes in pulse pressure variation. As you can see, the value of pulse pressure variation at 8 ml per kilogram was better in terms of prediction of fluid responsiveness than the value at 6 ml per kilogram. But the best was the change in PPV from 6 to 8 ml per kilogram, and we found a cutoff value of 3.5%. For example, if you have a patient with a PPV of 7% at 6 ml per kilogram tidal volume, you increase tidal volume, and now if your PPV value is 11%, you can assume that the patient would respond to fluid administration. If PPV goes up from 7% to 9%, you can assume that the patient will not respond to fluid administration. It is a very helpful test in the absence of cardiac output monitoring, because you need only an arterial line to perform this test. And in my experience, in patients with COVID-19 ARDS, because it is very helpful, because these patients are normally ventilated with a low tidal volume. Normally, they are highly sedated to be synchronized with a ventilator, and we can perform this tidal volume challenge, and we have very good results with this test. Another test is the end expiratory oxygen test. You know, this test consisting in interrupting the ventilator for 15 seconds at the end of the expiration. This results in an increase in venous return and preload, and this is like a preload challenge, and you can look at the changes in cardiac output at the same time to identify full responders and non-responders. With Xavier Monet and others in my institution some years ago, we showed that the increase in post-coronary cardiac output during the test was associated with fluid responsiveness, and we found a cutoff value of 5% to discriminate between fluid responders and non-responders. And this test is very helpful in case of ARDS, and we found in this other study with Xavier Monet and others that the increase in cardiac output during this test was better than PPV to predict fluid responsiveness. And this also can be very helpful in COVID-19 ARDS patients. And this is a meta-analysis we performed recently with Francesco Gavelli and others, and we pulled 13 studies that address the issue of fluid responsiveness using this end expiratory oxygen test, and we found good results with a summary area under the ROC curve of 0.91 with a good sensitivity and good specificity, and a cutoff value of 5%. Pacemaker test is another test which is very helpful in patients with or without mechanical ventilation. You know this test, which consists in moving the bed of the patient. It is a postural maneuver which mimics fluid challenge. And of course, no fluid is infused and the effects are reversible. So it is a very interesting test. And we can identify the field responders by looking at the hemodynamic response to PLR for 1 minute only. And in this meta-analysis with Xavier Monet and Paul Merrick, we showed in almost 1,000 patients that the changes in cardiac output during this passive aggressive test were very predictive of field responsiveness with an excellent area under the ROC curve and a threshold value of 10%. And this test is very helpful also in patients with ARDS because it performs very well compared to pulse pressure variation. And again, in COVID-19 patients with ARDS, it could be very interesting to perform passive leg raising, but you need, of course, a cardiac output measurement and a real-time measurement of cardiac output. And when we use a systolic arterial pressure or the pulse pressure, it does not work as well as if we look at the changes in cardiac output. We have a lot of false negative cases if we rely on the changes in arterial pressure only. And also, we cannot use the change in CVP. This is a study we performed with Olfa Hemzawi and others, and we showed that the changes in CVP during PLR cannot detect preload responsiveness. So again, we need a cardiac output measurement. And a contraindication of PLR is the presence of intra-abdominal hypertension. In this study with Alexandra Burton, Xavier Monet, and others in my unit, we illustrated on the poor ability of PLR to predict responsiveness in patients with intra-abdominal hypertension, essentially due to false negative cases. So if I summarize, in patients with shock, despite the initial resuscitation, it is important to assess the volemic status by testing fluid responsiveness as often as required, since fluid responsiveness is a dynamic phenomenon which can evolve over time. And today, many reliable dynamic tests are available, and even in case of fluid responsiveness, it is important to assess the benefit-risk ratio of giving fluids before any infusion of fluids, especially in patients with associated ARDS. And the benefit can be assessed by the degree of fluid responsiveness, and the risk can be assessed by indices of lung tolerance to fluid infusion, PF ratio, lung water, increase in POP, B lines, etc. In my unit, we use extravascular lung water, and I would like to finish by this study, which will be published in Critical Care shortly. This is a study where we looked at the values of extravascular lung water in COVID-19 ARDS patients and non-COVID-19 ARDS patients. And we subdivided the values of extravascular lung water in function of the severity. And we found that in COVID-19 patients, in general, on the day one, we have a higher rate of patients with high values of lung water compared to non-COVID-19 patients. And this was confirmed at day 2, day 3, day 4, and day 5, day 6, and day 7. So in general, it is associated with higher lung water. So we have to be very careful if we want to give fluid to these patients. And now I would like to thank you very much for your attention. Maybe there is maybe a pool question if you want to show and to try to answer quickly. This is my conclusion. I would like again to thank you for this, for your attention.
So this is the poll question from Professor Tabool. Please vote. You have 10 seconds.
Very, very simple question. If you follow my talk, you should answer these questions, just to confirm that it was simple.
Professor Tabool, please discuss the result as well, right?
Yes, if I show the results, of course.
Yeah.
cannot see the results now, but maybe it's not finished.
Shania, tell us when it's done. Yeah.
Okay. So, paced grazing is a good choice. Thyroid volume challenge is a good choice because you have just to look at the changes in pulse pressure variation, and there is nothing to do. There is no need of sophisticated cardiac output monitoring or other hemodynamic monitoring. And the expiratory occlusion test would be a good choice because the patient is perfectly sedated, and you have to just to interrupt the ventilator for 15 seconds. But pulse pressure variation is not a good choice because in general, these patients are ventilated with a low tidal volume, and the baseline value of PPV is not good enough because of the presence of false negative cases. This is why the tidal volume challenge is a preferred tool. And for you also, it is a preferred tool. So this is a good. Lung water is not a fluid responsiveness parameter. It is a parameter which can be used if you want to assess the degree of lung tolerance to give fluids before giving fluids. It's not a fluid responsiveness test. This is a lung tolerance variable. Right. So thank you very much again, Sheila, for this and for this invitation.
Thank you very much, Professor Tabool, for that excellent overview on fluid responsiveness and also highlighting the specific aspects of COVID-19. Now over to our next speaker. We are delighted to have with us Professor Daniel De Becker from Brussels. He is the head of the intensive care unit at the Chirec Hospital. He's also professor of intensive care at the University Libre of the Brussels University. And you all know him. He's been the past president of the European Society of Intensive Care Medicine. He has several publications to his credit. And he is really a doyen in echocardiography. He started the EDEC courses, organ dysfunction, sepsis, microcirculation especially. But today, we will request Professor De Becker to speak on echocardiographic aspects in shock and with a focus on COVID-19. Over to you, Professor De Becker.
So first, I'm really delighted to be with you tonight, and especially in these very, very difficult times of COVID-19 surge for the ICUs. It's true, especially in India, but of course it's still true in Europe at that time also. So echocardiographic assessment in shock, and especially in COVID-19, this is something we do every day, and I will explain you why it is important, and especially again in COVID-19. So we have indeed many of these consensus that now recognize the very important place of echocardiography in the management of shock, and especially when we need to evaluate the type of shock, it is very important to perform echo at some point, because indeed it will help to recognize what is exactly the type of shock. And why? For two reasons. The first one, the time to diagnosis is very short. So you just have to switch on the device, you put the probe, and in a few minutes, you already have the diagnosis. So it is, of course, non-invasive, but the most important aspect, it is very rapid. And not only it is rapid, but it's also reliable. Sometimes we say ultrasounds are operator dependent, but this is not exactly true. You see that different investigators have exactly the same assessment of the type of shock. So these kind of measurements are very easy. That's why in this review article, we indeed mention upstream that echo should be performed, and that we have indeed easy recognition of the different type of shock, the dominant one that is driving most of the alterations that the patient has at this specific time, this specific moment when you investigate your patient. And it seems that indeed it may be associated with some improvement in outcome. We do not have randomized trials, and it will be very difficult at the time where everybody is using echo, of course, what we still can say is that comparing before and after studies, we can see that indeed it helps in the management of fluids, in the management of hydropic agents, or it is associated with an improved urine output in these patients, and more importantly, a trend to an improved outcome. And using the large mimic-3 database, patients having had echo compared to patients not having had echo in the initial time, we can see that indeed patients with echo have better outcome, have some differences in the use of some agents with more fluids initially, but less fluids later on, and more lactate reduction, more creatinine reduction, and by different ways to look at the difference in outcome, survival rates. There is also an improvement in survival rate in this kind of observational data. So it is not the formal proof, but it is quite indicating that indeed echo is quite useful in these conditions. What should be done? What should be measured? Well, for beginners, because we have indeed several stages in the echocardiographic apparatus, looking at just pericardial effusion, the size of the right and left ventricle, the function of the left ventricle, and preload responsiveness by different ways is already a way to go, which provides a lot of information. I really suggest that just after this, measuring cardiac output by measuring aortic VTI is really one of the best way to go, and it gives you 95% of the information you need for looking at your patient. Then, of course, you can have much more information by trying to look at the pulmonary artery pressure by different ways, looking at the filling pressures, and of course also looking at morphological features, regional hypokinesia, valvular disease, but also patent foramen ovale, an important feature, especially again in COVID-19. Evaluating the cardiac function is really a crucial point when we begin to say, well, what kind of intervention do we wish to do? And then, of course, we have simple one, like the ejection fraction, and much more complex one that I will not discuss here, but we can look at the systolic function, diastolic function of the left ventricle, and of course, many indices of the right ventricular function or dysfunction. But what to do with the measurements? This is really the most important aspect. And remember that in sepsis, and this will be true in COVID-19, especially because remember the relevance of the cytokine release and so on. And this is especially what we also have, of course, in septic shock. So we have some myocardial depression. So globally, we have a very important relationship between function assessed by ejection fraction and cardiac output or cardiac index. But more importantly, when we want to treat, we need to see whether it is relevant or not to the outcome of the patient. And one of the very important aspects is that we may have some patients here with impaired cardiac function, but nevertheless, the cardiac output is not only preserved, but in this case, quite high. You can see that the average cardiac index of this group here is 4 liters. 4 liters of cardiac index, you probably have minimal benefit from first or increased cardiac index. So there is no need to give the butamine, levosimodal, whatever you wish to try to improve cardiac output in these patients. On the other hand, look at these patients here. You have an excellent cardiac function, but nevertheless, a low cardiac index. So again, if you just look at the cardiac index, you will say, oh, I will give some hydropic. No, look at the cardiac function. Cardiac function is very good. So you need to do something else to try to improve cardiac index in these patients. And maybe giving further fluids could be a solution, but maybe not. We need to assess really preload responsiveness in these patients. And then, of course, we have these patients here with an impaired cardiac output related to an impaired cardiac function. And these are the patients who may perhaps benefit from increasing their cardiac index if they respond, of course, to hydropic agents. We need to have a special look at the right ventricle by several ways. I will not discuss this too much, but looking at the dilation of the right ventricle is really a very important aspect. And we can even quantify this by looking at the respective volume or surfaces of the right and the left ventricle. In COVID-19, we have even more relevance for looking at echocardiography here. Indeed, of course, it is not easy. You can see here that we have to put some specific aspects to protect all cells, but also to protect the devices and to prevent transmission of the disease to others. So it's not that easy. We can admit this compared to regular patients. Nevertheless, it is still very important to remember that echo is a crucial point here to try to select the patients. And then we can look at what we see in these kind of patients. This is one of these patients with a significant impairment in left ventricular function. If we look at the aortic VTI, well, aortic VTI is relatively, it's moderately altered, but nevertheless, cardiac output is still not that bad. So we need to realize that there can be some dissociation again in between the function and the cardiac output. On the other hand, we have this patient here with biventricular dysfunction. You can see here a very poor left heart function, very poor right heart function. And if we look at the VTI, it is even better than in the previous patient. And here, again, very poor right ventricular function, not very good left ventricular function. And we can see here, yeah, VTI even higher than in the other one. So the dissociation between the cardiac output and the cardiac function is really crucial. And so we need to pay attention to both aspects, of course, when we do the echo. So there is in COVID-19 variable alteration in cardiac function with patient with predominant left ventricular dysfunction, patient with global dysfunction, patient with predominant right ventricular dysfunction. And all of these have variable impact on cardiac output. And also, we need to pay attention to the pericardium because pleural pericarditis is really frequent. You can see here some minimal aspect here, but there's a rat tail here, pericardial effusion, but you can see here the inflammation of the pericardium with all these B lines here, meaning the inflammation of the pericardium here. And you can also have these patients here with a really significant pericardial effusion in this patient here, still well-preserved cardiac function, and here, even more important pericardial effusion. And in this patient here, even some initiation of some initiation signs of cardiac tamponade that begin to occur in that patient together with impaired left heart function. So we can look at some trials looking at these aspects, and we have several of these, and all report almost the same. We have globally a little bit less than 1/3 of the patient with normal cardiac echo. We have patients with a significant right heart dysfunction and patients with significant left heart dysfunction. That can be systolic dysfunction and diastolic dysfunction. And a more recent paper with even more patients here, international, and again, normal echo here in a little bit more than 1/3 of the patient. Left heart dysfunction here in 1/4 of the patient, right heart dysfunction in 1/4 of the patient, and biventricular dysfunction in the other patients. And so a mixture of all the features that can be observed here, and even looking at just patient without pre-existing cardiac problem, again, the same aspect is found here. And when you look at the different aspects that can be found, really a huge variety of the findings. So we need to be really looking at very specific signs on echo to try to disclose all these aspects. So to conclude, in COVID-19, we have similar patterns as in patients with sepsis and in patients with RDS. The type of echocardiographic pattern cannot be predicted from clinical features or biomarkers, troponin, lactate, whatever, and even BNP. And pericardial effusion is quite frequent, and we need to pay attention to it because it can lead to tamponade. In addition, of course, we have to look at the impact of thrombotic events that also affect the heart in these conditions. And with this, I thank you for your attention.
Thank you very much, Professor De Becker, for an excellent overview on echocardiography. I now request Professor Divatia, who's the head of the Department of Anesthesia, Critical Care and Pain at Tata Memorial Hospital, to kindly introduce our last speaker.
Good evening, everyone, and thank you, Sheila. So it's my pleasure to introduce Professor Thomas Sherin. He's a professor of anesthesiology in the Department of Anesthesiology at the University Medical Center in Groningen, the Netherlands. He has worked and studied and worked in Germany and in Holland. He's done his PhD from the University Hospital in Düsseldorf, Germany, and a lot of studies on cardiovascular physiology. He has been he's been the chair of the section on cardiovascular dynamics of the European Society of European Medicine, and he's the editor-in-chief of the Journal of Clinical Monitoring and Computing. He's got a great interest in cardiovascular physiology, hemodynamic monitoring, especially the microcirculation and tissue oxygenation. More than 100 peer-reviewed publications. He's a great friend of India, and he's a delight to listen to. So may I request Professor Thomas Sherin to please start and talk to us about monitoring tissue perfusion.
Thank you very much, Jiggy, for this kind introduction, and Sheila for inviting me. Can you see my screen and can you hear me?
Yes, very well.
Okay. So I was asked to talk about tissue perfusion, and these are my conflicts of interest. But first of all, I would start saying that I'm very sad to hear the news about the pandemic in India, and I would like to express my deep respect, my sympathy, and my compassion to all my friends in India. And I hope that you will manage and safely come through this terrible crisis. And nevertheless, Dr. Sheila and Dr. Jiggy are to be congratulated for organizing this high quality webinar today in these difficult times. And I'm very honored and want to thank them for having me here to talk to you. Okay, so talking about tissue perfusion is the holy grail of hemodynamic monitoring. Because as Jan Bakker, one of our friends, just recently said, at the end of the day, we have to realize that the ultimate goal of resuscitation is the restoration or optimization of tissue and organ perfusion. How can we assess this? And this is from the consensus conference that has been shown earlier to you. And it's highlighted here that shock is typically associated with evidence of inadequate tissue perfusion. And this should be assessed by clinical assessment of the tissues like the skin, the kidneys, and the brain. And they recommend frequent measurement of heart rate, blood pressure, body temperature, and physical examination, and not to use only one single variable, but rather a combination of those. And so my talk today will be on the clinical examination, so not on expensive monitoring, because as these recent review articles assessing the clinical use of peripheral perfusion parameters also say that clinical examination is the key to assess the tissue perfusion at the bedside. And abnormal parameters of peripheral perfusion are important warning signs in the diagnosis and treatment of patients with shock. And an abnormal peripheral perfusion at various stages of treatment is associated with poor outcome in patients with shock. So coming to COVID, this is a recent survey that has been performed internationally, worldwide, on the hemodynamic monitoring and management in COVID-19 patients. And here you see the distribution of the respondents. And they said that tissue perfusion was assessed almost exclusively based on clinical examinations. It is a capillary refill time and biological evaluations, namely the lactate levels. So my first poll question, can we please have the poll questions to you, would be, what is a typical sign of impaired tissue perfusion? Is it mottled skin, acrocyanosis, increased capillary refill time, increased central toe-to temperature difference, or all of the above? Please make your choice. I cannot see the results yet. Can you see it or can you share it with me?
We'll end the polling now.
Yeah.
Okay.
So the majority has said all of the above, and the second closest one, 22%, is increased capillary refill time. But
So this
70%
shows,
have said all of the above.
yeah, thank you. I can see it. Thank you very much. So this demonstrates that I'm talking to a very educated and experienced audience. So actually, this is the right answer. So the correct answer would be E, all of the above. So let's just briefly see how to evaluate the tissue perfusion clinically. You can assess a mottled skin, or you can assess the fingers, the capillary refill time, or the central toe to temperature difference. So what is the skin mottling? These are the 4 or 5 stages of skin mottling. I hope you can see it on your screen. Alterations of the microcirculation as you will in the skin that you can evaluate, and you can inspect this and grade this. And the higher the grading, the higher the region that is affected around the knee, in this case, gives you a score. And this score is, as you can see here, correlated with survival. So the higher the score is, the worse the peripheral perfusion, the higher is the mortality, as has been shown in these 2 studies in patients with septic shock. A second thing is the capillary refill time. This can be performed on the sternum, on the knee, or on the index finger most easily. And pressure is applied for 5 seconds. This turns the nail bed or the fingertip white, and it's then released. You can see here, hopefully, this video showing how this is performed. And then you can also standardize these tests, because different examiners will have different pressures and different times, and this small device helps you to put a standardized pressure and a standardized time, and by doing this you can reduce the strength, the variation in strength and the variation in time, and this helps to standardize the test across different countries and between different doctors. And these are the normal values for these capillary refill times. So in children, it's less than 2 seconds. It's a normal value. And in older people, it's a little bit prolonged. Here you have a more specified distribution of the values. And this study from France has clearly shown that it can detect between survivors and non-survivors. The threshold value was 2.4 seconds, and the performance was even better at the knee than at the index finger in this study. And there's been a big study from South America, published recently, the Andromeda shock trial, which actually used the peripheral perfusion as a resuscitation goal compared to lactate. And they didn't find a difference because the study was underpowered. But at least the peripheral perfusion guided group was not inferior. It tended to be even better than the lactate guided group. So you can use the peripheral perfusion as a resuscitation goal to guide your treatment. The final point I would like to discuss is the temperature. So if you see like this, a bladder temperature, a central temperature of 37 and a peripheral temperature of this 32, a difference of 5, what is normal? And this is a very early publication from 1969 showing that there is an association between the temperature at the toe and cardiac output or cardiac index. And in those patients who survived, this toe temperature or temperature increased, while in those patients which finally died, the toe temperature decreased. And you can say that the temperature difference from the central part to the toe is 3 to 7 degrees is normal, is associated with normal tissue perfusion. But if the temperature difference is above 7 degrees, then we can assume that the tissue perfusion is impaired, and the likelihood of death in that case is quite high. Also, this this study has been looking at skin differences between the forearm and the finger, or the central to toe differences, and they could show that in patients where this difference is increased, they had abnormal central normal perfusion, and this was associated with a higher SOFA score and higher lactate levels in those patients with an impaired perfusion. So peripheral perfusion can be subjectively assessed and could identify patients with a more severe organ dysfunction. And this group, also coming from France, looked at the toe to room temperature, so the difference between the toe of the patient and the room temperature in more than 100 patients. And they looked at these different temperature gradient, but this is the most interesting one. So you can see here that the toe to room temperature gradient was significantly lower in the non-survivors than in the survivors, and it was related to arterial lactate level, urine output, capillary refill time, and mottling score. And this is the course over time. So this did not change in the persons who died, and it increased in the survivors. So the toe to room temperature gradient reflects tissue perfusion at the bedside and is a strong prognostic factor in critically ill patients, and it's very cheap. We performed in Groningen this simple intensive care studies, the 6 studies, where we looked at the clinical value of these physical examination in all the patients admitted to our ICU. And in this paper, we looked at the prediction of mortality, and we can see that the central temperature difference actually predicted mortality, as did the skin mottling. And in this paper, we looked at if we can even predict acute kidney injury in our patients. And again, the subjective cold temperature at the periphery or a prolonged capillary refill time at the sternum were independent predictors of acute kidney injury in our study. And it's even better if we combine these tests, like the skin perfusion, the temperature, or the capillary refill time and the mottling, because each test has a moderate positive and negative predictive value. But if you combine them, and even with blood pressures and heart rate, and the more you combine, the better becomes the accuracy of these tests. And this has been verified by this editorial accompanying one of our articles, that clinical examination is an essential part of the assessment of the critically ill patients. And coming back to COVID, this is just a suggestion how to evaluate patients, COVID patient, with acute respiratory failure, he's not intubated. So you look at the peripheral perfusion. If it is okay, you might go on with fluid restriction. But if he is in shock or has acute kidney injury, then you could do one of the tests that Professor Teboul already showed you to evaluate if this patient is fluid responsiveness, and you have several monitoring devices depending on whether you have an arterial line or not to see if this patient is fluid responsive. So taken together, my take-home message is that clinical examination is a key to assess tissue perfusion at the bedside. Monitoring tissue perfusion helps you to identify the subgroup of patients that are at higher risk. It can unmask persistent shock in apparently well-resuscitated patients based on macrohemodynamics, and to assess the response to therapy and to redefine the targets of resuscitation and probably transfusion. Monitoring tissue perfusion should be therefore incorporated as part of our daily diagnostic approach. We are all doctors, so look at your patient, touch your patient, even if he has COVID, to see how the periphery is perfused. Because if the systemic macrocirculation is severely altered, the peripheral perfusion is probably also disturbed, but the restoration of the systemic hemodynamics in terms of blood pressure or cardiac output does not necessarily mean a normalization of tissue perfusion. So tissue perfusion should be taken into account to predict an effect of your interventions also. However, optimal agents and strategies for augmenting tissue perfusion have yet to be determined. And with that, I thank you very much for your attention.
Thank you, Professor Sharon. We will now go into a quick question-answer session. Dr. Sheila, if there are any questions that we've received for
Yes, we've received actually a lot of questions. Since we're a little over time, I'll try to put them together and combine some of the questions. And they're not addressed to any specific speaker, so I may ask this to any of you. I'll start with Professor Michael Pinsky. I know, Professor Pinsky, you're driving, but I hope you will be able to take the question. So, Professor Pinsky, the question is fluid overload and volume overload, are they the same?
First of all, I'm not driving. That would be dangerous. My wife's driving.
Okay.
As you can probably see, the car is moving. But anyway, they're not the same thing. You can have total volume overload with interstitial and edema in the periphery, and it's not the same thing as hypervolemia. We want to separate the two out. You can have hypervolemia without volume overload transiently, but eventually there has to be leak of the fluid out. But on the opposite is not true. You can have excessive volume overload and have interstitial blood volume hypovolemia. This is why peripheral edema per se is not a reason to not give fluids if the person is behaving like they're underfilled and have a volume responsiveness. Okay. So that's the response.
Thank you. So another question that is I'll also like to ask you is is it important to weigh patients in ICU, and also considering that the COVID patients already have lung involvement, is there a role to give early vasopressors to avoid this kind of fluid overload?
Well, there's no reason not to weigh the patient. It's not going to change my therapy early on, but it will change it later when I continue to dialyze them or diurese them once they're stable and they're resuscitating. It's a nice thing to do, but it's on the side. I'm a big fan, as are I think all the speakers here, of early vasopressors to maintain organ perfusion pressure so as to minimize the amount of fluid that's necessary. I think that's very useful. I think Professor Tabul just submitted a paper on just that specific aspect, how giving norepinephrine could increase mean systemic pressure and therefore the pressure gradient for venous return, and would minimize the amount of extra fluid you need to give the patient. So I'd like him to answer that too, because we are, after all, a round table.
Right. Professor Tabul, your thoughts on this? And there are many questions. You're muted. There are many questions for you after that. So early vasopressor, COVID patient. The question was, which Professor Pinsky has forwarded to you, is in COVID patients, because of the lung involvement, should we start vasopressors early rather than give to avoid fluid overload? Is that a better strategy in COVID, specific to COVID patients?
It is a good strategy. It is a good strategy, but Professor Pinsky already finally explained why. First, because norepinephrine is able to increase blood pressure, which is a good thing when you have a patient with shock, and fluid administration is not always associated with improvement in arterial pressure, first. Second, because as said by Professor Pinsky, you can improve the mean systemic pressure, and therefore you can have a more effective blood volume in the stressed compartment. And this can be very helpful for the patient, because this can auto-transfuse some blood from the unstressed blood volume to the stressed blood volume. So you cannot give, you do not bring fluid, you give blood. This is better. And also it can improve contractility also at the beginning of the septic shock, because it has an action on the beta-1 receptors, which are not yet down-regulated at the beginning of shock, of septic shock, for example. And also it can reduce the volume of fluid by definition, and there are many studies showing that there is a reduction in the volume of infused fluid for the same targets if you give norepinephrine early. So many reasons to give early norepinephrine, and you can, of course, limit fluid overload.
Thank you, Professor Tabul, for giving us that excellent explanation. There's a lot of questions related to PLR. I'm going to club them together. So people have asked about PLR and intra-abdominal pressure. What is the role of using end-tidal CO2? And which is the best technique of monitoring cardiac output when you're using passive leg raising? So 3 questions together for you.
Okay, so untitled CO2 is possible. It is a surrogate of cardiac output if you have no other change in the patient. So it is a little bit touchy because sometimes you could have some changes, but if you have no change, the patient is mechanically ventilated, perfectly sedated, synchronized with the ventilator, you can rely on the change in end-tidal CO2. There are at least 2 papers about this showing that PLR the effects of PLR can be assessed by the changes in end-tidal CO2 in mechanically ventilated patients. Another thing is that if you use PLR, what is the best technique?
Of measuring cardiac output. Should you use invasive, non-invasive, or which technique?
Whatever, provided that it is a real-time cardiac output monitor or measurement. You can use echo and look at the changes in VTI. If you have no other devices, if you have echo, you can use echo. It is little bit difficult than to look at the changes in pulse contour cardiac output. Nevertheless, you have another thing you can look at VTI changes, velocity time integral changes during PLR. And also you can use any other invasive or non-invasive cardiac output monitors. For PLR, I think that it could be, all these techniques are reliable.
Just to ask you about, a lot of people use PLR with, they interpret it using an arterial line. They don't have continuous cardiac output monitoring. So how reliable is that? Can we just look at the pulse pressure and can we make interpretations?
You can look at the systolic or the pulse pressure, but you should know that there are some false negative cases, meaning that real fluid responders in terms of increasing cardiac output can be missed by the changes in arterial pressure. Sometimes arterial pressure does not change, systolic or pulse pressure do not change, but cardiac output increased. So this is the definition of false negative cases. If you have nothing else, of course you can look at this, but it is better.
What you're saying is it should be real-time cardiac output monitoring is what you're saying. And the last part about intra-abdominal pressure, when the intra-abdominal pressure is high, is it reliable to look at PLR?
As I showed in my presentation, it was a very short presentation, so I went very fast. One of my last slides was related to the issue of intra-abdominal hypertension. In the paper I showed, in patients with less than 12, we have a good reliability of PLR test to predict fluid responsiveness. In patients with more than 12 milliliters of mercury, we had it was less reliable, and we have a lot of false negative cases, meaning that cardiac output increased during after fluid infusion, but did not increase during PLR in this situation of intra-abdominal hypertension. So we have to choose another test.
So one last question for you. You mentioned about the paper and the high extravascular lung water that was seen in COVID patients. Was this also associated with high PVPI?
Yes.
Can you just comment on this as to the implications of these findings?
We looked at the PVPI results in this paper, of course. I have no time to show all the data, but we also have a higher PVPI in patients with COVID-19 compared to non-COVID-19 ARDS patients. So this increase in lung water was associated with an increase in pulmonary vascular permeability index, meaning that there is a problem of permeability of the capillaries and not a problem of hydrostatic pulmonary edema in this situation.
Okay, Professor Divatia, if you want to take a few questions. So, meanwhile, I'll ask Dr. Daniel De Becker, what about VTI variation for looking at fluid responsiveness? Variation in the VTI. Can you comment on that?
Well, so variations, I think that variations in VTI are excellent, as well as pulse pressure variations, but the prerequisites to use pulse pressure variations are identical. So if we have a low tidal volume, if we have a respiratory movements, if we have a right heart failure, all these will affect the aortic VTI. The advantage with ECOs is at least we will detect right heart dysfunction, which is not the case with a blind assessment with other aspects. But beyond that, it doesn't offer advantages over pressure. And if anything, perhaps the error in measurements may be perhaps a little bit higher with VTI changes than with pulse pressure, which is much more easy to measure. If we are discussing now the aortic VTI changes during passive leg raising, this is again very good, but this was already covered by Jean-Louis Teboul a few minutes ago. And so the problem is to be sure that there is no change in the angle when you change the position of the patient. So it's a little bit more tricky. When you are experienced, you can do it very easily, and there is no problem and no issue with this. But of course, you need to be very cautious to be not changing the angle and to be very accurate in your measurements, both when the patient is in both positions. So that's a little bit the complications there, but otherwise it's excellent.
Professor Diwatia?
Yeah, so Professor Rebecca, there are a couple of more questions for you. So do you think echocardiography can help you select your vasopressors or inotropes? And if you have to monitor or measure or estimate cardiac output, would you rely on echocardiography, or would you prefer to use something like flow track or one of the arterial contour type of monitors?
Well, there are two questions there. The first one is how do you select the monitoring devices? And that's true that the echo is quite good there because when you detect significant right heart dysfunction, you would perhaps propose different monitoring techniques compared to when there is no impairment in right heart dysfunction. When there is some impairment in left heart dysfunction, most of the monitoring devices perform similarly. So there is no major differences there. And what we usually do still, and especially of course in COVID, when entering and leaving the room is not that easy compared to other patients, is really to use echo in addition to other types of monitoring. Relying solely on echo is a little bit more complicated because, again, performing the echo itself is a little bit more cumbersome in COVID-19 patients than in other septic shock patients. Regarding the question about selection on vasopressors, inotropic agents, yes, I mean, this is the key of the use of echo, and especially for inotropic agents. I don't think that we can easily in 2021 continue to indicate inotropic agents without having hemodynamic assessment indicating that heart function is impaired before giving an inotropic agent. Just detecting a low cardiac output is not enough to indicate inotropic agents.
Professor Rebecca, I have one question for you. So specific to COVID, I mean, we're trying to be less invasive. Do you think echo kind of scores higher in this setting because, you know, it's non-invasive and you don't want to put in, you know, PA catheters or continuous cardiac output, unless, of course, it's advanced hemodynamic monitoring. Do you think there's a bigger role for echo now in these cases?
Yes, but again, the real problem is the fact that we need to protect ourselves, to protect the devices, and to be cleaning the devices, and all these kind of things make the repeated use of echo a little bit more complicated. So if you just have one patient to treat, it's easy. If you have several patients to treat, it begins to be a little bit more complicated.
Yeah. So question now for Professor Sharon. So, you know, you very nicely highlighted, you know, that clinical monitoring of tissue perfusion is extremely important and that's what should be done. But, you know, when you're wearing PPE and, you know, you've got a double mask, you've got eye goggles, or you've got a face shield and you're wearing gloves, and, you know, so how easy is it to look at tissue perfusion and monitor the temperature or the temperature difference in the extremities when you're all dressed up like that?
This is an excellent question, but I just wanted to stress that what I often observe is when I come to the ICU, doctors standing like this because they are afraid of touching the patient at all. And this is not a good way, because for assessing tissue perfusion, we have to look at the patient. And of course, it's difficult to evaluate the skin perfusion with your fingers, or the temperature to feel it, but we can measure it. This is a cheap measurement with a skin thermometer, or we can do the capillary refill time with which is also not invasive, and it's also done with your protection on. So my message was, don't stay away from the patient just only because he has COVID. You still have to approach your patient and evaluate your patient clinically, even if he has COVID.
Okay, great. So there's a question regarding something about arteriovenous PCO2 differences. So what is the role in detecting tissue is there a role in detecting tissue hypoperfusion, and what is the utility of a measurement like the CO2 difference?
It's also an excellent question. So what the PCO2 gap, as I used to call it, is telling you beyond just the cardiac output number is if that cardiac output that you measure is adequate for the metabolic situation of your patient in that situation. So even if you have a high number of cardiac output, it might still be inadequate. And the PCO2 gap, which is also quite easy to assess, measure, you just need a blood sample, arterial and a central venous, can tell you if your patient if the cardiac output is adequate. So if the PCO2 gap is increased, you might consider further resuscitating your patient, even if the cardiac output number seems adequate.
Okay. One last question, for you, Dr. De Backer, is can you just clarify on this IVC assessment for fluid responsiveness in spontaneously breathing patients, in mechanically ventilated patients? When is it useful, less useful, not useful?
So inferior vena cava variations is relatively useful because it is something which is, when adequately measured in the adequate patient, it's a very good measurement. But the problem is that we have a lot of patients with active contraction of the diaphragm and or abdomen, and this makes the variation of the inferior vena cava less reliable. So in the fully sedated patient, it's quite easy. But then you have other ways to assess fluid responsiveness, and so it's one in this we take in addition to the other one to try to have the full picture there. When we have patients who are spontaneously breathing, it's also useful, but then we need to be cautious on the ventilatory pattern of our patients. In COVID-19 patients, we see these patients. They are usually they are breathing quite rapidly, and the excursion of the diaphragm is also quite significant. So in these patients, the strength of the contraction of diaphragm and abdominal muscle is a little bit higher than in other patients. So in these spontaneously breathing patients with COVID-19, I don't rely so much in these patients.
Right. If there are no more questions, Professor Divati, are there any more questions? Because we are running late.
We can go on to the case. Right? I think we've covered most of the questions in this discussion, and perhaps some other questions might be addressed when we talk about the case.
So we'll move on now to the last part of the session. This is a short case that we've prepared, and it's specific to a COVID patient. And I'd like all the speakers expert panelists to participate in this. The international speakers have already been introduced. I'd like to introduce our three national experts. The first expert is Dr. Deepak Govil. Dr. Deepak Govil is from, he's the head of the intensive care unit at Medanta, the Medicity, Gurgaon. And he's also the current president of the Indian Society of Critical Care Medicine. He's been the past Vice Chancellor of the Indian College of Critical Care Medicine. And we are very happy to have Dr. Deepak Govil with us. He also heads the WIN Focus, the Delhi division of the WIN Focus, looking at echocardiography. And then we have my colleague, Dr. Atul Kulkarni, who's the head of the intensive care unit. He's been the past president of the ISCCM as well, and runs a very elegant course called Thematic on Hemodynamic Monitoring in our department, which is very, very popular. And we also have with us Dr. Srinivas Samavedam, and Dr. Samavedam is from Hyderabad. He is the medical director of the Vinci group of hospitals there. He is the vice president of the Indian Society of Critical Care Medicine. He's the associate editor of the Indian Journal of Critical Care Medicine. So welcome to all the national panelists, and the international experts have already been introduced. So without any delay, I'll just put you through the case, and I'll tell you that I've made this very short because I like to have more discussion rather than give you too many details of the patient. And I've deliberately left out some content because I would like you to comment on this. So I'll just start with the case. Now, this is a 52-year-old male, and he's a policeman by profession. He has no comorbidities and no significant past history or any addictions. And he had dry cough, fatigue, and loss of appetite since 3 days. And he's had fever since 2 days, about 100 to 101 degrees Fahrenheit. So this is the brief history that he had. He's been tested positive. RT-PCR is positive for SARS-CoV-2. And these were the tests that was done when he was at home. His hemoglobin was 12, white cell count was 8,000, procalcitonin 0.5, CRP was 20, and this is the normal range. And urea 34, creatinine 0.8, and this is his, the electrolytes, the liver function test was normal. So these were just the basic labs that were done when he was in home, and he was advised home isolation, and his vital parameters were stable. Saturation was 96. And he'd just been advised to take paracetamol tablets SOS when he has fever. Now, after 2 days, he got progressively breathless, and he had fever was 102. His heart rate was 120, blood pressure was 130 by 80. Respiratory rate was 28, and he was maintaining a saturation of 92 at home. But this was dropping to 85 when he did a 6-minute walk test. So the family physician advised that he should go to the hospital. He presented to the emergency department. And when he came to the ED, he was confused, but he was obeying commands. This were his hemodynamic parameters: heart rate 130, blood pressure 120 by 80. Respiratory rate had increased to 30, and he was maintaining 90% saturation on air. And he was started on oxygen via the non-rebreathing mask, and he was on 10 liters of oxygen. An IV line was secured, and his saturation increased to 94, but the respiratory rate, increased to 35. He was not very comfortable. He was more tachypneic after starting the non-rebreather mask. And so finally, he was put on high-flow nasal cannula oxygen, flow of 50 liters, and he was on a FiO2 40%. And the patient felt much more comfortable. His respiratory rate came down to 35. His heart rate came down. The blood pressure was 120 by 84, and his saturation was 94. And because he was on high flow, they decided to transfer him into the intensive care unit. Now, here in the ICU, the patient, he was oriented, but he was looking extremely fatigued and very tired, still on high flow, which was now increased to 50 liters, and he's on 50% oxygen. Heart rate, the respiratory rate has come down. His heart rate is 110, blood pressure is 100 by 84. Saturation was 95 on this. His peripheries were cold, and just general systemic examination, the cardiovascular system, respiratory system seemed okay. Other systems seemed unremarkable. An ECG was done, which was normal. The screening echo was done. A DVT scan was normal. I'd just like to ask the panelists that is there any other test that you would like to do at this point? Any other labs or any further examination? An arterial line was put in. The BP was 110 by 80. Pulse pressure variation was 15. So I'd like to ask Professor Pinsky, at this point, would you like to have any more any more details? These routine lab investigations were done. Is there anything else you would like to have? He was comfortable on high flow and shifted to ICU for further monitoring.
A couple of things. One, I'd like to know tissue perfusion. So I'd like to know if he has a urine output, if they measured a lactate, what his capillary refill time is. The tachycardia is obviously a stress marker, but at this point in time, and a pulse pressure variation of 15 is what you'd expect with somebody breathing rapidly and deeply as they do, as I think Jean-Louis Thibault described. So I would, at this point, the additional information I'd like to know is he in shock? And if he's not in shock, then I would say, okay, let's just hang in exactly as we are, because he seems to be responding nicely to high flow oxygen. And clearly, in terms of treatment, you'd be wanting to give him the various antiviral medicines plus steroids that we would give these people. But other than that, I would want to know shock.
Moving to that, I'd just like to ask you, just looking at this, would you say this patient is in shock?
No.
His pressure is 100 by 84.
No, but that doesn't tell you anything. I'm sorry, Sheila. That doesn't tell you.
You need more information, right? So
hypotension, if you wait for hypotension, you've waited too long.
Okay, right. So Dr. Srinivas, I just want to say that, sorry, this intensivist, he looked at the cold peripheries. That's the information he had. Do you think he should have assessed further? What would you look for in this kind of patient? Just on a general clinical assessment. Dr. Srinivas.
The question that's been asked is about, are you assessing this patient for shock? Yeah. Apart from the cold peripheries, I think the capillary refill time would have given us some clue whether there is a hyperperfusion. The altered sensorium, the confusional state is confounded by his hypoxemia and his anxiety with his work of breathing, so we cannot totally attribute it as a part of the organ hyperperfusion. We may probably have assess his urine output and see whether the renal perfusion is adequate or not. And if you extend the arterial blood gas as a clinical tool now in intensive care, now that he's in the ICU, I would look at his base excess and his acid-base status as a clinical sign of organ hypoperfusion, although the hypoxemia itself could contribute to the hyperlactatemia, if at all, in the ABG. So I would look at the capillary refill time, his peripheral mottling, his blood gases, and then make an assessment.
Yeah, I think Professor Sharon gave us an excellent overview on that. Professor Sharon, would you like to add something regarding the clinical assessment? I will show you the labs and the X-ray and everything. You're muted. Would you like to to add something to this?
So Dr. Srinivas pretty much summarized what I also presented in my talk. So looking at the capillary refill time, you're saying the peripheries are cold, but this can be quantified. So you could measure, especially the difference to this core temperature and the mottling score he also mentioned. But I would like to comment on the blood pressure, although Professor Pinsky told us that the blood pressure tells us nothing. It's because it's not hypertensive, but it tells us something. If it's measured correctly, it tells us that the amplitude or the pulse pressure is very low. And this might be indicating that the cardiac output or the stroke volume is very low. So I'm not agreeing with Professor Pinsky that the blood pressure tells us nothing. It's telling us that it's not hypotensive, right? But
this was using non-invasive. This was not an arterial, right? This was non-invasive. Coming to you, Professor Thibault, again,
Sheila, can I just make a comment?
Yes, Professor.
What I said was a normal blood pressure doesn't tell me anything. That's what I said. I didn't say blood pressure is nothing.
The important point you're making is that you could have a normal blood pressure and the patient could still be in shock. I think that's what you're trying to say, right?
Yes, that is correct.
I want Professor Thibault to comment, one, on the blood pressure, and secondly, the pulse pressure variation is 15. This is a spontaneously breathing patient. Can you comment on that? Is this parameter of any value in spontaneous breathing?
Yes, thank you for the question. I agree. I fully agree with Thomas Sharon about the pulse pressure, which is very low, only 20. It means by definition, it means that stroke volume is low. When we compare to the pulse pressure before, it was 50. The first measurement was 50. So I mean that right now we have a pulse pressure more than the half less than at the beginning, meaning that the stroke volume is probably at least more than 50% less than at the beginning. If you have a low stroke volume, it is due to either cardiac dysfunction, which is not the case here.
So the echo was done, the echo was normal, the ejection fraction.
Yeah, so it was due to hypovolemia, of course, due to hypovolemia. So this patient is hypovolemic right now. There is no other test to do, which is sure, 100%.
Can you comment? I know PPV is not of value when you have a patient who's spontaneously breathing, but if you have a high value during spontaneous breathing, can you comment on that?
Yes, but in patients with spontaneous breathing activity, I don't care about the value of PPV. It could be low, it could be high, it depends. And because, as you know, there is no stable and no regular breathing in patients with breathing activity, and the amplitude also of the intrathoracic pressure is different from one cycle to another one. So I don't want to look at. I don't want to.
Dr. Kulkarni, your comments at this point, would you say the patient is in shock?
Well, it's very unusual to have cold peripheries in somebody with fever, right? Plus, we know, as I agree with
Dr. Kulkarni,
Professor Tebul, that the stroke volume seems to be very low in this patient. So I'm surprised that somebody with fever has cold extremities. Okay, so that's my problem. The second thing is the pulse pressure variation in somebody who is struggling to breathe is not going to tell us much, because there will be wild swings in the intrathoracic pressure. Correct. And in any case, the patient is breathing spontaneously.
Okay, correct. So I'll just move ahead. This was his X-ray. So it looks like a reasonably normal X-ray. And a quick lung ultrasound was also done. Dr. Govil, will you comment on this? And will you also tell us what would you specifically look for in a COVID patient when you're doing lung ultrasound? Dr. Govil?
Yeah. Thank you, ma'am. So whenever we do a lung ultrasound in a patient of COVID or any other lung pathology, we have to just imagine what is going on in the lung. COVID being a disease which spreads to the periphery, and there is a consolidation more on the bases and less on the apex. So we expect the same finding in the lung ultrasound. So in lung ultrasound, mainly we look for 3-4 things. One is the lung sliding to rule out any pneumothorax. That is the first and foremost thing. If there is any pneumothorax, then the lung sliding won't be there. Or if there is any blockage, mucus plug or something is there, then lung sliding won't be there. Then we look for the pleural surface. If in the COVID and any other viral pneumonia, there should be some subpleural consolidation, and what we call as a shredding of the smooth pleural surface. Like here, I can see the pleural surface is very smooth. White shiny line pleural surface looks like smooth. But in the COVID patients where there is a pneumonia, this white line will be shredded. It will be broken in between, and some pleural consolidation will be there. Then thirdly, there will be a lot of B lines. B lines could be sparsely placed or could be confluent or could be conjoined B lines, depending upon the wetness of the lung and the deep consolidation. And then finally, we'll find the consolidated lung, which is more at the bases than the apex. So if we combine these findings and compare both the side of the lung, because this disease is mainly the bilateral disease, so then we come to the conclusion. Right. And so these things keep on the second week maximum.
So you think this is a useful tool in our armamentarium to do a quick
this is very useful tool, because at the bedside in 2 minutes, you can judge what is going on, and you can see whether your patient is improving, not improving, or deteriorating. And it is very easy tool to identify the pneumothorax in such patients in COVID, where the getting X-ray done is not very easy.
Right. So in this patient, again, the X-ray was unremarkable and the lung ultrasound findings seemed to be okay. Coming to the lab, his hemoglobin was 15. This is white cell count. Coagulation profile was normal. The CRP was high. This was a ferritin. And the IL-6 was elevated. Urea was 64, creatinine 1.1. And this is your electrolyte findings. This is LFT was normal. Procalcitonin was 0.4. Nevertheless, a blood culture was sent. And are there any other investigations? Any of you can take this, would like to, any other further labs that you would like to have? Professor Pinsky?
Sheila, before we go on to labs, I presume that this patient was given some fluid. You know, I mean,
no, fluid was not given. An IV line was taken, and yes, an IV pint was started, but no fluid boluses or anything like that.
No fluid bolus.
Yeah, the BP was normal, and because the patient was very tachypneic, and
well, I'm not really sure the BP is normal in this.
Yeah, so this is an intensive. This is what the intensive has actually done. So I'm just telling you the findings. So the intensive.
No, so the urea seems to be going up, isn't it? From the previous slide.
So my question first is, would you like to have any other labs? Dr. Tabul, Dr. Kulkarni, any of you can take this. Any other labs that you want before we discuss the findings?
I presume we have done lactates. I mean, a blood gas, and we looked at the lactates.
Is just coming. Anything else? Yes, an ABG will be done.
Yeah.
Any other test? Any of you? Some more information?
Sheila, yes, I would like to have lactate not for the value now, but to follow over time.
Okay.
The application of lactate, of course, but at that time.
Any kind of interpretation? Do you think, Dr. Kulkarni, this blood culture should have been sent? Of course, the patient had fever.
I would have sent it when we put in the arterial line. I mean.
But with the procal 0.4, do you think looking for bacteria?
Well, it may not be a secondary infection, but it's not always that only bacterial infection can cause septic shock. I mean, you can have.
Dr. Pinsky, would you send a blood culture at this point? I mean, this is a patient we know who's COVID positive and a procal of 0.4. Do you think we should send blood cultures like we do in septic shock and patients like that, sending routine blood cultures? Anyone can take that. Anyone can answer that. Dr. Srinivas, Dr. Shiran.
Dr. Debekar wants to answer this question.
Yeah, Dr. Debekar, please. Yes. Anyone can take this, yeah.
Well, I don't know if you hear me.
Yes, you do.
So among the culture, I think that we need to be very systematic in these patients. I know that there could be some associated costs, and we may perhaps not be at the same page in some places in India and in Europe or US. But in our department, we are systematic as we are in septic shock. And what we observed is that even though the admission blood cultures are very seldom positive, I mean, we have up to 1/4 of our patients who have some bacterial infection within the first week. So everything depends on the time spent on the ward. Right. I have to admit, in our units, patient just on high flow oxygen therapy would be not admitted to the ICU, but will be admitted to a high flow oxygen therapy unit. And so this will come later to our units when they deteriorate.
So that's very, sorry, go ahead.
One thing that I would be knowing if perhaps the dimers, even though they are usually elevated, we still have not ruled out at this stage the potential risk of pulmonary embolism. Even though the DVT scan was negative, it doesn't mean that there is no pulmonary embolism in these patients. So there is often some dissociation between DVT scan and pulmonary embolism. So
that's a very important point you made. You're saying though the DVT scan was negative and the echocardiography was normal, there is value in doing a D-dimer.
I missed the point that echo was normal. I mean,
yes, it was normal. But, so my understanding is D-dimer has more of a negative predictive value in terms of pulmonary embolism. So echo was normal. Sure. So that's it. So thank you very much. That's a very important point, because I'm sure in India we would send a blood culture, but it's interesting to hear that you said 1/4 of your cultures and you would suspect bacterial infection, even though this patient has come from home and has not been on the ward. That's really very interesting. So a blood culture was sent, and this is the first blood gas. And as you can see, this is a pH. The PCO2 is 41. And this is the PO2, the base excess, the hemoglobin is 10.5, and the lactate is 3.24. Dr. Srinivas, would you just quickly tell us, interpret this blood gas for us, if you don't mind?
if you look at this blood gas, the pH is in the normal range. So it's easy to pass it off as a normal blood gas. So if you look at the PCO2, again, normal, bicarb is normal, the base excess is normal. So I wouldn't say that there is a major acid-base disturbance in this ABG. But if you go through the, is there a lactate on the ABG?
Yes, there is.
I can't see the lactate value on this.
Sorry, the lactate is 3.24. And the electrolytes are also here. I hope all of you can see it. It is 3.24, the lactate. So the lactate is elevated.
There is a hyperlactatemia. There's no doubt about it. The anion gap is about 100 and is about 14.
Yeah.
So there is a hyperlactatemia without an acidosis, but the fact is that if there is an anion gap, there has to be an acidosis. So if you interpret the blood gas from that perspective, whenever there is an anion gap, there has to be an acidosis, and there is a hyperlactatemia on this image.
Thank you very much. Now, before I go on to the interpretation of this findings till now, I'd like to ask a poll question. So Shania, if you're ready, can you ask the first question? I would like to know, Shania, please. Yeah. So the question to our audience is this patient in shock?
Shall we look at the answers?
Okay, so you can end the poll now. Wow. So we have 88% who are saying, yes, this patient is in shock. And 14, I saw it was almost becoming 100, but it came down to 88. But 14% still say this is not shock. So I'd like your comments on this. So Professor Tabul, can you just throw some light on this? This was a patient who came, like you said, with the blood pressure was borderline, but the resident felt it was normal. And this patient has an elevated lactate and is still tachycardic, but on high flow, he's quite comfortable. So do you think this patient is in shock? A majority says, yes, this patient is in shock.
Yes, I do. I do. I think that this patient is in shock. From the beginning, he was in shock. Again, because we cannot...
Why do you say from the beginning? Why do you say from the beginning?
No, from the beginning, because he was dehydrated at the beginning. He has a high sodium concentration. He was hypernatremic. He has 149, low pulse pressure, cold extremities, and now we have the lactate value, which is high. If you don't say that this patient is in shock, you can forget this, concept of shock. Of course, it's in shock. Of course, it is hypovolemic shock. The problem is, should we treat shock or not? Because we have COVID-19 pneumonia. So maybe could be.
I'll come to that in a bit. I want this highlights a very important point made by Professor Pinsky, that you can have a normal blood pressure. Well,
yes,
it was normal, but you can still be in shock. So this is a patient with an elevated lactate. And I'd also like to say that in the second wave, we're seeing a lot of patients who are coming, very dehydrated with elevated lactates. Their blood gases look something like this. This is from a patient in our unit. And the lactates are elevated and they actually require fluids. So Shania, if you can put up the second poll question for this clinical setting, I'd just like to know, Shania, second question, please. So I'd just like to know from the audience another poll question as to how you would manage this shock now that you say this is shock. What should I give him? Should I give him fluids now? Should I give him vasopressors? Should I just give both fluids and vasopressors? Just do nothing? Or something else? Is this just a messenger, a marker of severity? Should I just disregard this lactate? Just do nothing?
I presume the blood pressure is the same on invasive.
Yes, the blood pressure is the same. Yes, this is the blood
on invasive monitoring as well.
Yes. It is the same. Yeah. So very interesting.
Shall we look at the results?
Yeah. So we can look at the results. So 81% majority says give fluids, and this is followed by give both fluids and vasopressors. And about 7% say no fluids, just give vasopressors. Now remember, this was a patient with a normal echo, a normal lungs, and normal lung ultrasound. Dr. Govil, I'd just like to know from you, what would you do? You're muted, sir.
Difficult question, ma'am. First of all, I would like to give fluids for a bolus, maybe in 20 minutes or 30 minutes. If his blood pressure does not come into the category of hypotension, so only lactates are high, so I'll probably give only fluid, nothing else.
So your initial thought would be to give fluid.
Fluids,
Professor Sherin, what would you do in this setting?
I also voted for fluids. Because the blood pressure is still acceptable at this point, so there's no need for vasopressors. If we have a reason to be careful with fluids, then I would recommend giving a vasopressor early, as we discussed previously, but not at this point.
Let's talk about this setting, Professor De Becker. In this setting, with this patient, with a normal echo, normal X-ray looks okay, ultrasound looks fine. Would you want to start vasopressors on him? The blood pressure also seemed normal to the resident. Only lactates are high. Do you think that's reasonable to go with fluids first?
Yeah, I would go for fluids first. The risk at this stage is relatively limited, given the fact that we have no B lines, that the echo is really normal, and that, as mentioned by Dr. Bull, the patient was dehydrated with a hypernatremia. So all these factors suggest that the patient is severely hypovolemic and that fluids should be the first line. And because blood pressure is really quite normal with 80 of diastolic blood pressure, I don't think vasopressors should be there. The option now. I think that if you intubate the patient, vasopressors will be mandated, but not now.
Yeah. So I think that's a very important point. Professor Tabul, can you throw a little light on the diastolic pressure? The diastolic was 84. I think Dr. De Becker brought out a very important point. So how does that determine whether you give vasopressors early or vasopressors late? Because there was a combination of choice of combination as well. So yes, can you tell us about that?
This is a good point. Of course, I would have voted for fluid only first. And I would not, as others, I would not have given vasopressors because, again, the vasomotor tone is not depressed at that time. And we can rely on the diastolic blood pressure, which is 84. So it is okay. And when we have a low diastolic blood pressure, in general, it is associated with low arterial tone, which is not the case here. At that time, of course. If you intubate the patient with sedative drugs, maybe it would be another story. But at that time, I think that we don't need to give vasopressors. Again, the diastolic blood pressure is enough, and we don't need at that time.
So I think, thank you very much, Professor Tabul, for highlighting this point. So I think all the experts agree that it is reasonable to give fluids at this point, and there's no reason to jump to give vasopressors. And Professor Tabul has made a very important point that look at the diastolic pressure. If the diastolic pressure was low, then perhaps the approach would have been different and there would be a recommendation for early use of vasopressors in this patient. So this was there in the ICU. The fluid was given, about a liter of fluid was given to this patient. And the blood pressure, this was the blood pressure now, the lactates kind of came out after some fluid resuscitation. And Professor Pinsky asked about the drugs. The patient is on steroids. Clexane has been started, enoxaparin and remdesivir. If Professor Pinsky is still here, I'd like to ask, what kind of fluid resuscitation would you like to give? Would you like to give, if this patient, say, came with
Sheila,
yes, Dr.
Sir, all the attendees seem to be saying that there is some background noise in one of our.
Okay, right. So whoever it is, please mute your mic unless you're being asked a question. Thank you for that, sir. So is Professor Pinsky here, or anyone can take that question? So supposing this patient came with a little lower blood pressure, supposing this patient was in shock, high elevated lactate, but also low blood pressure. So should we just give, how much fluid should we give? Should I give 30 mils per kg, Professor Pinsky, as the surviving sepsis guidelines recommend, or should I, what should be my approach? Dr. Sherin, Professor Sherin, any of you could take this question. I think Professor Pinsky is not here. Professor De Becker, Dr. Srinivas, what would be your approach? Anybody?
So we if I can take this, you mentioned the 30 milliliter per kilo, which are recommended in the Surviving Sepsis campaign. I'm not a friend of fixed numbers, although we all agree that this patient needs fluid at this moment, and maybe the 30 is what ends up. But I would not recommend giving fluids without assessing fluid responsiveness. And Professor Teboul gave us an excellent overview of how we could do this. So we should. Not now, because we now all agree that the patient is in need of fluids, so we can give blindly this 1 liter that you gave. But for further fluid administration, I would rely on a measurement of fluid responsiveness and give further fluids only if the patient is in need of fluids, or if we have a.
So Professor Sharon, we are talking about initial. We just have an outline in. And Professor Teboul, would you like to summarize how I should have this approach? Because I'm not doing any advanced hemodynamic monitoring at the moment. It's just basic tools I have in my monitoring.
I fully agree with Professor Sharon about this. At the beginning, during initial resuscitation, in case of septic shock, and this is not a septic shock, but it is COVID-19 associated shock, and but it is the same reasoning. You need to, we detected hypovolemia, evident hypovolemia in this patient. It is logical to give fluids because lactate was high, etc. So there is no discussion about, no debate about this. There is no need at the beginning, no need to use a fluid responsiveness test.
Yes.
We have just to give fluid because it is obvious. We cannot wait for too long time. And so 1 liter, why not? And I think that this is good. And ringer lactate also is good in this situation.
Right.
But after 1 liter, I totally agree with Thomas. If we think that we need to, if the patient is still in shock, we need to assess fluid responsiveness because there is a high risk to give fluids to a patient who would not be.
If I understand what you said correctly, a very important point, you don't need to assess fluid responsiveness when a patient just comes in with shock. You need to fluid resuscitate him. But instead of having the approach of just giving a huge volume of fluid initially, even in its initial resuscitation, you may give perhaps 500 to a liter, and you can always reassess. Maybe a patient needs more than 30 mils. So that's the kind of approach that you're recommending. Okay, so this is what was done for this patient. And this is now the next day in the ICU. And this patient is still on high flow, but the FiO2s have gone down. And he's now satting 90%, the flow is 60. And he's quite tachypneic. The respiratory rate has come up to 35. And blood pressure is okay. Heart rate is also very tachycardic and quite tachypneic on high flow nasal cannula oxygen. So the resident decided that this was time to probably intubate him because he was very uncomfortable on high support. And he was intubated, mechanically ventilated, and of course sedated on assist control mode. He received protective lung ventilation. He's on a PEEP of 10 and the saturation is 94%. He's on 40% FiO2. And these are his parameters. Now his heart rate is 130. And immediately after intubation and the initiation of mechanical ventilation, the blood pressure dropped to 78 by 58. His MAP is 63. The pulse pressure variation at this time is 10. Lines have been inserted. The CVP is 14. The central venous oxygen saturation is 65. The mixed venous oxygen saturation, And here the IVC variability was more than 30%. He's still got persistent fever, and now the resident has started an antibiotic and given piperacillin tazobactam 4.5 grams TDS. So he got intubated, and soon after intubation, there was hypotension, as we usually see. So if anyone would like to comment on this, and Dr. Divatia, perhaps you can take this forward. I'd like to have comments from anybody. Dr. Kulkarni, Dr. Srinivas, Dr. Govil, anybody can come now.
Okay, so I will disregard the CVP of 14 because the patient is on 10 PEEP, and we don't know how much of that intrathoracic pressure is being transmitted. So that really doesn't tell me much. I presume the patient is just been intubated and there are no spontaneous efforts. So PVV is borderline. My problem is that his pulse pressure still seems to be the same. Okay, so there is a problem with his stroke volume, and I would like to look at his heart again. I mean, I presumably this is because of intubation and initiation of.
It was immediately after intubation. Immediately after.
Yeah, yeah. So I presume it is because of the positive pressure ventilation initiation, plus your drugs for intubation, etc., etc. But that low stroke volume is still worrying me.
Okay.
I would probably try a 250 ml bolus. Patient is hypoxic or the saturation is borderline. So I don't know what to make of this central venous saturation of 65%. Yeah. Because presumably we have resuscitated him before intubating him. Probably needs to get some vasopressor on board.
Right. So, Professor De Becker, would you like to comment on any of these findings? The high CVP, the mixed venous oxygen saturation, the 65, or IVC variability, which is more than 30%. I mean, what do you make out of all this?
Well, with a PEEP of 10, IVC variability above 30% is really, and a patient deeply sedated, as you mentioned, this is really deeply pathologic, and this can only be observed in fluid responsive patients. So cardiac tamponade will not give this, right heart failure will not give this. So you will have instead very dilated and not respiratory dependent IVC. So fluctuating IVC in a deeply sedated patient is very highly suggestive of this fluid responsiveness aspect. The question is no. Will this patient tolerate fluids or not? Given the fact that it is only 40% of FiO2, I guess that at this stage the patient will still tolerate it, but we have to admit that the balance between the benefits and the risks begin to be a little bit more debated. So we have indeed a CVO2 which is low, because indeed in most COVID patients, it's especially when they are sedated, SCVO2 is often higher than 70, even 75%. So it again points out toward the low cardiac output in this patient, and we need to know a little bit more about lactate and other signs of perfusion and maybe urine output in these conditions now, because the indication of fluid is that we should have a problem, not that we see fluid responsiveness. So the blood pressure is just on the low side, and this will not be enough to perhaps justify fluids. Tachycardia for a sedated patient is really troublesome. So I guess again that this suggests a very low stroke volume, and so all the factors go more in the direction to give fluids, but I would like to have a bit more information on.
You would like to be guarded with Professor Tabul. I see Professor Tabul. Give us your interpretation. Yeah,
I totally agree with Daniel. I would like to emphasize on the fact that CVP is 14. I agree with Dr. Kulkarni that it does not mean anything in terms of cardiac function, for example, but it means something about the pressure, the back pressure for organ perfusion, which is high. CVP is high. And we know what is important for organ perfusion. I speak about the kidney, for example, is the difference between MAP and CVP, which is here 63 minus 14, which is 49. And 49 is not enough. 49 is not enough, and we need to have more. In general, we need to have at least 60 for the difference between MAP and CVP as the mean perfusion pressure. So probably there is something to do with blood pressure. could be either to give fluid, of course, because this patient is fluid responsive. I don't want to comment more. This patient is fluid responsive. At that time, PPV is high for 6 ml tidal volume. PPV is high. IVC variability is high. We can perform a tidal volume challenge to confirm, just to confirm that the patient is fluid responsive. There is no doubt about fluid responsiveness. As said by Daniel De Backer, maybe if you give fluid, the patient would not tolerate fluid. So we need more than this. We need maybe another monitoring device.
You made two very important points. So one is about the CVP may not be useful in this case to assess fluid responsiveness, but it's of course has other values, and knowing the CVP can be beneficial. Like you said, mean arterial pressure minus the CVP and you know the MAP, and you look at that and you can target higher values. And the other important point that you made, if you look at the pulse pressure variation here, is 10. So it would probably suggest that this patient is not fluid responsive, So, but you are on low tidal volume. So perhaps there is a low role to do tidal volume challenge in this patient. So I'll just move to the blood gas. And this is the ABG of this patient, the blood gas in this setting. Professor Sherin or anybody, Dr. Govil or anybody can comment on this blood gas at this point. And these are the values, Professor Sherin, and now the lactate is 5.61.
Yeah, so the lactate increased, and now he is actually acidotic. So this is clearly a progression of his shock state and his impaired tissue perfusion, what we can see here in the blood gas analysis, clearly.
Right. So the FiO2 increased further, the PEEP was increased, and this patient was fluid resuscitated, like rightly said. After giving tidal volume challenge, the PPV increased and the IBC variability remained. So guarded fluid was given, the heart rate came down, the blood pressure was 120/70 after this. Lactates also came down marginally, the SCVO2 was 77. The P2F ratio subsequently remained low, and it was less than 150. So this patient was prone and he was started on neuromuscular blockade. And after 16 hours, the P2F ratio improved in this patient. And this is the X-ray that you have. And if you can compare this with the previous X-ray. And Dr. Govil, this is the lung ultrasound findings. Would you like to comment on this?
So now, as you can see here, there is a disruption in the pleural surface. So I can find out 2-3 disruptions in the pleural surface. So this is, can you point out, Dr. Sheila, this point where the pleural, so this is the pleural disruption, and right here there is a subpleural consolidation which is taking place. Right. And you can see the pleural disruption is there just above the arrow mark, Professor Sheila. So just go to the, this one. So here the disruption is there. In between these two lines, there is a subpleural consolidation. And from here you can see few confluent B lines are arising. And same like here, in the other point, just on the right side of the first line, you can see here another subpleural consolidation and disruption in the pleura. Just go to the right side. This point. So this is what we commonly find in such type of patients. But here I couldn't find a dense consolidation. So probably the echo probe, the ultrasound probe was kept on the upper area of the body, not at the basis.
Just in the interest of time, since we're running late and we want to conclude, so a CT scan was done. And if any of you could just comment on this CT scan, this is a classical CT scan that you would see in COVID-19 patients. Dr. Srinivas, Dr. Kulkarni, anybody who want to comment on the CT scan? Anybody would like to comment on this? Dr. Srinivas?
Looks like posterior consolidation on both sides. Looks quite bad actually.
Right.
I'm surprised the PF ratio has improved to that extent.
It's 180 after proning. So Dr. Govil, again, this is subsequently the next day, this is what we're seeing. So will you comment on this very quickly for our trainees, what you're seeing here in the lung ultrasound? Dr. Govil, you're muted, Dr. Govil.
Sorry. As the picture is here at the end, one can see the pleural line, although there is no movement. This is a still picture, so it is little difficult to comment whether this sliding is present here or not. But I presume that in the N, where the N is written, the sliding is present.
The sliding was present,
at this end point S, where the S is there. So there is some pleural consolidation, and this is the shadow of the rib, and there is some disparity between the two lines. So probably this area is having a consolidation. I'm not clearly able to see the whitish part. Could be the consolidation, could be some fluid as well. It looks like more of the fluid than the consolidation because the pleural line is here, straight lines.
Right.
This, if the moving sliding is there, then one can comment.
Yeah, right.
So Sheila, can I just comment for a minute here?
Yeah, please, Dr. Devatya.
So Deepak, in your experience, how good is lung ultrasound at serial follow-up of these patients? You know, that you don't have to do a CT scan and all, but how reliable or how good is the lung ultrasound to follow up progress or otherwise?
They are very good. We keep on recording every day so that at the end of 2-3 days, one can compare. And if one person is on the duty on every day, then it becomes very easy because then the operator remains same. If there is an operator variability, then things can go wrong a little bit. Yeah, but it's a very easily reproducible and comparable because one can have a record of serial ultrasound every day. And at the end of 5-6 days, one can compare.
Very important point, especially because of the logistic challenges of taking the patient for a CT scan. Dr. Devatya, please take this forward.
Yeah. So Atul, I also had one question. Say maybe Atul can take it and we can ask someone, Dr. Tabul or someone. How good are these indices of fluid responsiveness, you know, in the prone position? When you're ventilating a patient 16 hours in prone, and at some stage you have to decide whether or make a decision whether or not to give fluid. So how good are these PPV and tidal volume challenge and all these in the prone position in ARDS? Atul?
Yeah. So I would think the heart-lung interaction would remain the same. The only difference between COVID and non-COVID patients that I would think would be that initially there were descriptions of patients with high lung compliance ARDS. So in these patients, in those patients with small tidal volume changes, you may not get sufficient positive pressure changes. Apart from that, I don't see there to be any differences in the supine and the prone position.
Professor Tabul?
Yeah, this is a very good question, Dr. Devatya. I agree with Dr. Kulkarni about this. Heart-lung interaction should be the same in prone or supine position, should be the same. Nevertheless, there are a few data in the literature. There is a paper contesting the value of PPV and also the value of tidal volume challenge in case of prone positioning. A paper coming from Lyon, from France. We are investigating this issue, and I cannot give you data because the study is ongoing, but I have not the same impression than the team of Claude Guérin in Lyon, showing that the indices of responsiveness cannot be applied to prone positioning. I have the feeling, looking at the data, that we can still use tidal volume challenge. We can still use an expiratory occlusion test in this situation. So I think that as a tool, I think that we can rely on the classical fluid responsiveness indices in this situation, but this needs to be confirmed by papers.
Professor Devatya, just an extension to that, what about echocardiography now in prone position? What are the challenges in, 16 hours you're keeping up?
Prone position. Well, your patient first has a pneumothorax, so it's difficult because it's just in front of the heart. So transthoracic echo will be very difficult in this specific patient. In more general, transthoracic is not feasible in prone position. Transesophageal is feasible, but of course you need to be really skilled in inserting the probe in prone position. But we do this very regularly, and this is not a major issue to perform.
Okay, so can we go on then?
Yeah, please.
Yep. Okay, so this patient is now continuing on ventilation. You know, he's still hypoxic, 70% oxygen. Seems to get a little better with proning. Now he's turned supine, and now his BP is pretty low. The diastolic is 38. Saturation is 90%. Okay, and these are his numbers. CVP is low. It's lower than what it was. PPV is 14%. IVC variability seems to have increased, and he's still got an acidosis with a lactate of 3. So at this stage, there's a question for the audience. If you can put it up, Shania. What would you like?
Is this on vasopressors or this is without vasopressors?
No, nothing has been started as yet. Right. So what would you like to do? And this is actually one of the questions. This is what part of the question. Do you want this patient now to get some fluids, start a vasopressor, or both, or do nothing, or do something else? Okay, so start voting, and I think in a short time we'll get the answers. But in the meanwhile, Dr. Srinivas, can you just tell us what worries you about now? Because I'm in all this. What are the significant changes as compared to the previous numbers that we were seeing? Srinivas, can you hear me?
Yes, sir. Yes, sir. I can hear you.
Yeah.
The acidosis has crept up. And the fact is that this patient is hypotensive. FiO2 is fairly high. Saturations are not very great. And hemodynamics are again a major issue. So what concerns me is that are we going to react to this IVC variability with fluid? If yes, what is its ultimate effect on the volume status of the oxygenation status of the individual, and what will be its effect on the acidosis? These are the things which are actually going to hit me now. That decision making.
It's very interesting because there's almost a split between people saying start vasopressors and start both fluids and vasopressors.
Okay, so I think most people would start a vasopressor either with or without fluid. So I think vasopressors are very much on the cards. And I think like we saw, the key difference here is the diastolic for the first time has actually gone low. It's only 38. Whereas previously the diastolic was quite good. And there is some element of fluid responsiveness if you look at the IVC variability and the PPV, right? So I guess vasopressors are definitely on the cards. Now, Deepak, would you want to do any further assessment at this stage? This patient
is already supine, so we can do like PLR or anything here at this point of time. Okay. And in the proning position, I would like to make a comment, although I'm drifting from the original question. In the prone position, sure, we can do the PLR and look at the carotid flow velocities, compare the carotid flow velocities. That can be done very easily. At the end, if time permits, we can have the comments of Professor De Baker also on that thing. So coming back to here, I would like to again reassess the patient. Patient is hypotensive also, would like to rule out any pneumothorax by doing the chest ultrasound, look at the bases, what's going on. Patient is already having IVC variability. We can do a PLR with this VTI variability, and that's it. So the quick head-to-toe assessment can be done. Look at the DVT again, both the legs for femoral vessels or anything.
Okay, so we did
and of course the contractibility of heart also.
So an echo, right? So this is the echo. Now, if you can see the echo, so now comments from you, Deepak, and then
so it looks like the right side is grossly dilated. So right, could be a pulmonary embolism. We could be dealing with a pulmonary embolism, or could be a acute rise in the pulmonary pressure, which is causing the right side to be dilated. But it looks like a pulmonary embolism. We'll do as I already discussed, the DVT examination, look at both the femoral vessels or popliteal vessels with ultrasound. And if we feel they are having some flow inhibition, or there is a flow defect, then probably we can go for a thrombolysis as well.
Okay, so Dr. De Backer, so the differential with Dr. De Govil has provided us is one is acute pulmonary embolism, or maybe an acute cor pulmonale, right? Because of severe ARDS and positive pressure ventilation and stuff. So Dr. De Backer, what would be your thoughts on this?
Well, it's difficult to make the difference between the two causes of the right heart, acute right heart dysfunction. That's why here transesophageal echo would be quite interesting, because for such a severe right heart dysfunction, it should be significant clots in main or in the proximal segments of the pulmonary artery, and this should be seen. This kind of a severe right heart dysfunction is maybe just present due to the severity of RDS in this patient. In this condition, I would prone again the patient very rapidly.
Okay, so you would try and correct the hypoxia, hypercarbia, get the patient prone. Anyone would want to think of doing, say, a CT pulmonary angio, Atul or Srinivas? Professor Tabu, Sharon? Atul?
I wanted to emphasize again on the diastolic arterial pressure, which is low, 38 in this case, and in presence of tachycardia. Normally, when you have a low, when you have tachycardia, you should have a high diastolic arterial pressure. Normally, it is something which is normal because you have a lower diastolic time. And therefore, the diastolic arterial pressure should be higher in case of tachycardia. Here, not only is not higher than normal, but it is far lower than normal, 38, meaning that probably the vascular tone is totally depressed. I repeat, totally depressed. And therefore, there is a need of urgent vasopressor in this patient without thinking about anything else, without thinking about giving fluid, because you have just to correct blood pressure, which is low. The mean arterial pressure is low anyway, because if you subtract mean arterial pressure and minus CVP, you have a low MAP, minus CVP. So you should do something about blood pressure. And because, again, the vascular tone is very low, you should give vasopressors. And after, you should think again what to do after correction of arterial pressure.
So, Professor Tabul,
I may make one point. So thank you. This is a very important point that you made. And again, coming back to what you said in the beginning, that you were looking at the diastolic pressure, and the diastolic pressure was on the higher side. And now the story is, it's completely done a U-turn where the diastolic is low. And the importance of a low diastolic with tachycardia is probably a very ominous sign, and that should be a big alert. So this is a very important point in hemodynamic monitoring. The low diastolic itself should alert you to start vasopressors early. But if it's in combination with tachycardia, that should be a big red flag.
For example, if you have the same diastolic blood pressure and a heart rate of 80, it is not the same story about the urgency to give a vasopressor.
Right.
So Professor Tabul, half the audience said they would give fluid along with vasopressor. So we all, I think, appreciate the low diastolic pressure needs urgent treatment, but maybe because of the PPV and the IVC variability, they've gone for fluids as well. Now, can you comment, in the light of this right ventricular dysfunction, what is the value of the PPV and so on?
Okay, first, as I said before, I would have first given vasopressor and see what happens after, because we probably will have a new situation, and we will see what happens in terms of RV dysfunction, in terms of fluid responsiveness, etc. So I would have given vasopressor first, and after look at what happens after. Maybe the situation would be different. Regarding your question, in presence of RV dysfunction and high PPV, I would be very prudent, careful about the interpretation. First, because CVP is not very high. CVP is not very high, only 6. So meaning, and again, a part of six is probably probably due to high PEEP. I don't know what was the level of PEEP now. How was PEEP?
It was 12.
Well, so maybe 1/3 of PEEP or 25% of PEEP is is transferred to the thorax and is transferred to the CVP value. So if you subtract maybe 4 centimeters of water, meaning 3 milliliters of mercury from 6, it is only 3, meaning that the amplitude of RV, the degree of RV dysfunction in reality, if the numbers are true, is not very important, if you want, first. Regarding the reliability of PPV, if I have any doubt about this, I would perform a tidal volume challenge. And if PPV is going up, or maybe not tidal volume challenge, a passive leg rising test. If the patient is in supine position, of course, if the patient is in supine position, I would perform a PLR test and look at PPV. If PPV is going down, it means that the patient was full responsive before the PLR test. If PPV does not change, probably it means that the PPV value was related to RV dysfunction, okay? This is a way to distinguish between both, only if the patient is in the supine position, because you cannot perform a PLR test if the patient is in a prone position.
That's an excellent point,
Dr.
Yes, Dr. Devansh.
Yeah. So I think that was a great point about how to interpret the PPV in the setting of right ventricular dysfunction. Okay. Srinivas, would you want to do a CTPA, a CT pulmonary angio to rule out an embolism in this case? Or what would you want to do?
Well, in the context of COVID, yes, definitely yes. If his markers are suggesting that there is a very spurt in the D dimer, or I have found a substantial increase in his oxygen requirements, in the context of COVID, yes. But in the context of a pneumonia, ARDS producing hypoxemic respiratory failure, I would probably interpret this RARV dilatation and strain as a hypoxemic strain on the right heart, and not just a phenomenon correlated to pulmonary thromboembolism. But yes, definitely in the context of COVID, it's definitely, and shock, definitely it's one of my investigative tools at my disposal.
So, next slide.
Yeah. So would someone want to do some more monitoring at this stage? Any more monitoring from what you already have? Can we have an audience poll on this? Shania, would anyone want to do continue with the same monitoring, do something more? What would you want to do? You've got an echo, you've got an arterial line, you've got the echo which is showing you right heart strain. You want to do something more to see? So Atul, at this stage, tell me, would you like to go out for a CT angio, or would you just, or you want to do some tests to confirm or rule out or rule in embolism?
I would do a CT angio, particularly because this is a COVID patient. I mean, segmental and subsegmental emboli are quite well known and coagulate thrombi are quite well known in patients with COVID-19. As far as advanced monitoring is concerned, I would be interested in extravascular lung water most of all, because other cardiac information is being given by the echocardiography. I agree, and I understand that if you have if you are working in Dr. Goville's unit, you will probably get consistent ultrasound readings, and that may guide your fluid therapy. But in this patient with a PF ratio of 180, I would like to fine-tune my fluid therapy using the global endoscopic volume index and extravascular lung water index. So it depends. If the patient is, I mean, if it is possible, I would certainly have put in a transpulmonary cardiac output monitor in place long time back.
Okay, great.
It's very interesting to see, sir, that most want some form of advanced hemodynamic monitoring.
Right. Next, please. Next slide. Next slide. Yeah. So in fact, a PICO was put in, and these are the numbers. The PPV is 16%. The cardiac index is not great. The GDVI is 800, which means it's little. It's maybe the upper limit of normal. The extravascular lung water is 12 and the PVPI is 4. So Atul, since you're so fond of the PICO, what do you think we should do with these numbers? What do these numbers mean and what do you think we should do?
Well, the extravascular lung water index, there are many studies, some of them come from Professor Tebul, that as the extravascular lung index increases from beyond 7 ml per kg, then you start getting increase in mortality, and beyond 21 the mortality goes extremely high. The global endoscopic volume index, I think there are two numbers, one is 800 and the other is 850. So if you look at the purely the global endoscopic volume index, you have some chance of giving fluid. So I'll be very, very guarded in giving my fluid therapy in this patient. Probably take the global endoscopic volume index to about 1000 and 1000, and extravascular lung index, I would hope that it will stay there, and titrate the hemodynamics using noradrenaline to start with, which is extremely important because the diastolic pressure was so low, and maybe add dobutamine if possible later on. I mean, it depends. All patients will not tolerate dobutamine in such a state.
Professor Tebul, your comments? Would you give more fluid, and how do you interpret these findings?
I agree. I agree with what Atul said. In this situation, it is very interesting to see these values, these numbers, because finally lung water is not so high. The beauty of lung water is to be sometimes very high and sometimes not so high for the same PF ratio sometimes. Therefore, you can have some idea about the tolerance to fluid administration. In this situation, because it is not so high, maybe I could give fluid if I have a certainty of fluid responsiveness in this patient. PVPI is a little bit high, meaning that there is an alteration of the permeability. And maybe if you give fluid, you can have some worsening of pulmonary edema, but we can monitor. So I would be very careful, but in this situation, I would give fluid if I have the certainty that the patient is fluid responsive. If lung water was maybe 25 or 20, maybe I would refrain fluid administration.
So, Professor Tebul, what you're saying is, in this setting, if you're convinced that this patient is fluid responsive, you would give a guarded...
If the patient is still in shock also.
Professor Debek.
Still in shock plus fluid responsive.
Professor Debek.
Well, we have seen the echo just before. The right ventricle is dilated. We have severe hypoxemia. We have minimal increase in extravascular water. At this stage, I would test for, well, I will not give volume, given the dilation of the right ventricle. I would first test right to left shunt by giving contrast, because perhaps, given the minimal increase in extravascular water and severity of the hypoxemia, well, there is something there which is abnormal. And so perhaps there is a right to left shunt, and then changing the ventilatory conditions would be the key factor.
Professor Sharon, if the patient's, given this patient's current hemodynamic status, how would you assess the tissue perfusion? And let me ask you this, if the tissue perfusion appeared to be okay in your judgment, would you push for more fluid or vasopressors, or would you just leave it like that? Or how would you go about, everything is a little borderline. You give too much fluid, this could be a problem. You give vasopressors, the BP seems to be more or less stable. So how important would you put tissue perfusion in making your next decision, whether to be a little more aggressive with fluids or vasopressors, or just sit back, wait and watch?
So I would give an essential role to the tissue perfusion just in such a situation where we have borderline information about the volume status. And if the peripheral perfusion, which is, as I said in my talk, the holy grail of what we want to achieve with our resuscitation, if this is telling us that the patient is still in considerable shock, then I would put this as a very important piece into my puzzle for my management plan, in this case, giving further fluids if it's positive.
Right.
Okay, great. So I think that's again a good point. If everything must be directed towards tissue perfusion, and if tissue perfusion seems okay, maybe we can just take a few deep breaths and wait and watch and then decide what to do next.
Well, I think that's a very important point. I would go with Dr. Rebecca that perhaps not to give and look for other causes. And if at all you give, you have to be extremely cautious, as Dr. Tabul said, and integrate this with your parameters for tissue perfusion. So this is just coming to the end of the case, Dr. Devatya.
Yeah, so I think we did consider pulmonary embolism, but we were reluctant to shift him. The DVT scan was okay. Troponin only mildly increased. The D dimers were not very high, so we just maintained him hemodynamically. We started noradrenaline, did not give fluid. Prone ventilation off and on continued, and with God's grace, patient gradually improved. Was weaned off vasopressors and eventually extubated. So happy ending to a sad story that the world is facing.
So thank you very much. I know we've already overshot the time, and I'm really grateful to the speakers for staying on almost an hour. If there are any quick questions that we have, Dr. Devatya, from the audience, we can take that. I think there are a lot of questions, lots of questions actually for the speakers. So if you can take perhaps just one or two questions, I would be.
One of my questions I discussed, probably Professor Tabul or Debekar can answer that. What is their take on the carotid flow velocity in the prone position? Can we?
Can you repeat? Sorry.
So doing VTI variability is impossible in a prone position if we try to do a PLR or sort of maneuver to check the fluid responsiveness. Can this carotid flow velocity help in that or not? Like we have trying to do in few patients in prone positioning. I don't know
VTI,
whether we are doing the right thing or wrong thing.
Yes, you speak about VTI, velocity time integral.
Is not possible because aortic VTI is not possible. So if we do a PLR maneuver, PLR sort of maneuver, it could not be a true PLR in the prone position. And we measure the carotid flow velocity, change in the carotid flow velocity.
I understand. Sorry, I did not understand. I understand now. First, PLR is not possible. So some people use the Trendelenburg maneuver.
Yeah, exactly.
Trendelenburg maneuver and consider that an increase in cardiac output by more than 8% means fluid responsiveness. So I have no data about what you said, looking at the velocity of the jugular vein.
No, carotid artery.
Sorry?
Carotid artery.
Well, I have no idea. I have no data. Maybe it's good. It's a good way if you perform a Trendelenburg maneuver, postural maneuver, which is not PLR because it's not possible, but Trendelenburg maybe. We need some data to be sure, but it is an excellent point. Yes.
Thank you.
Okay,
right. Professor Sharon, you want to say something? Yeah.
Yeah, I just want to ask the audience or the speakers. So you mentioned, Jean-Louis, change in cardiac index of only 8%. Are we sure that we can detect such a small change in cardiac output reliably in that situation?
Yes, this is a good point, Thomas. I said this because there is only one paper coming from Jean-Christophe Richard from Lyon. I already talked about this before, showing that the threshold value was 8%. Maybe it's not 8, maybe it is 7, maybe it is 9. Of course, we don't know, but it's around 8%. As you said, we need a very precise technique to measure cardiac output. So, for example, if you use pulse contour cardiac output monitors, whatever the monitor, pulse contour, it is a very precise technique. Maybe it's not always accurate, but it is a precise technique. So you can rely on the change, on the trends, and you can use this for this maneuver because 8% is above the coefficient of variation of this technique, which is around 2%. So this, regarding echo, For example, of course, it is difficult to perform echo during prone position, as said by Daniel. Regarding echo, I'm not sure that you can use this kind of technique for measuring 8% change, because the precision of echo in general is not as good as the precision of pulse contour cardiac output monitors.
Right. There's a question for you, Professor Tabul, or anyone could take it. So what is the value, or perhaps Dr. Sharon can take this. What is the value of this PCO2 gap? How do you interpret this difference? Professor Sharon.
How do I interpret which difference? Do we have a value?
Yeah, so if it is say 8 or if it is 3, how do I, what is the interpretation of this?
So if we measure PCO2 gap, like you mentioned, in millimeters of mercury, it would be a threshold of between 5 and 6. If it's above that threshold, then we would consider it abnormal, and we would consider that the cardiac output at that point is not adequate, or we have a severe microcirculatory disturbances preventing the CO2 diffusing from the periphery back. If you measure like in kilopascal, like we do in the Netherlands, then the threshold would be 1 or 1.2.
Okay. So the other question is,
may I add something?
Normal? Yes, Professor.
No, I would say I totally agree, of course, with Thomas. But I always use in the opposite direction. I mean that if PCO2 gap is normal, less than 5, 6, I don't think about increasing cardiac output.
Right.
This is what I want.
Is, and anyone could take this, that what is the normal lactate and what should be considered as an alarming rise? Professor Debacker, Dr. Govil, Dr. Srinivas, anybody can take this, Dr. Kulkarni. What is the normal lactate value? And when should you say, oh, this is alarming? I'm worried now.
Well, the normal lactate value is around 1, but we accept indeed that 2 is a threshold to be detected. But we have to be very cautious on when we are measuring lactate. I mean, here in this patient, we are already on day 3 or 4. So at that time, it begins to be less accurate as a detection of tissue hypoxia. I mean, many other factors begins to play a role, including the delayed elimination of lactate by several mechanisms, including the production of lactate in inflammatory areas, and especially in severe RDS, we need to pay attention to this. So on the first day when we saw the lactate rising, then it was really a major issue, and it was associated with other signs of hemodynamic impairment. Later on, it begins to be a little bit more complicated. And then, of course, we need to have additional signs, and just lactate should not be, in isolation, should not be a sign of impaired tissue perfusion.
Another question, and that's again to you, Professor Debacker, that is there anything new in assessing IVC variability for fluid responsiveness? Anything with the limitations, or anything different that we should be doing now?
There are a lot. Well, there are a lot of limitations for inferior vena cava, and again, I think that these were already pointed out before. And one of the major issue is that it is one sign among others, and I really do not like to take this sign in isolation, because it's probably the less accurate sign compared to the other signs of fluid responsiveness. So I like to look at it, but never or seldom in isolation.
So I think that's a very important point that you made, that none of these tests are perfect, and you need to integrate all of them and make an assessment. So you cannot say that this is just the PPV is the best or IVC variability. You need to integrate these findings, especially when you're in doubt with other parameters for fluid responsiveness. There's Professor Manimala Rao, who's an intensivist and previously cardiac anesthetist, and she said she was very happy to see from Professor Sharon's talk that people are still looking at toe to peripheral to central core temperature difference, and she said she's very happy to know a senior intensivist that is still an integral part of hemodynamic monitoring. There's a question on tidal volume challenge. Someone's asked about PEEP. Yes, you maintain the same PEEP, and you make sure that during the test you don't alter the PEEP value, and it will not affect your test. And the last question, and I'd like many questions I repeat, so in the interest of time to wind up the session, I'd like to ask to all the speakers, and anyone can take this, that how would you assess, we've been talking about fluid responsiveness. So how will you assess fluid overload? So what should we be looking for? So anybody can take this question as a last question before we wind up. Yes, Professor Tabul.
Yes, if you want. In general, when the patient has been admitted for days and we are thinking about what to do, fluid removal, for example, we look, in my unit, we look at fluid responsiveness again. When the patient is not fluid responsive, we can think about this strategy of fluid removal. Of course, we also base our reasoning on our strategy on the presence of high lung water. So it is another way to do high lung water and relatively low PVPI associated with fluid unresponsiveness could be a good indicators to think about a fluid removal strategy. So there is no, I have no answer to your question how to diagnose fluid overload. For me, it is not this way of thinking. It is how to decide fluid removal. For example, in a patient with hypoxemia, and maybe in my experience for COVID-19 patients, we had a lot of patients like this in the past, but also still now. And sometimes after some days of ARDS and ventilation, we have some patients who can benefit from fluid removal, really.
Yeah, so I think the point of the question is that you have this patient with ARDS, and then you also have hypotension and shock, and you're given some volume resuscitation. And now it's difficult to wean off this patient if he's got a very positive fluid balance. So in that sense, what is your take on this? And then giving diuretic therapy or the de-escalation phase, as we call it. Any of you can take this question, Dr. Google, Dr. Srinivas, Dr. Kompany. Dr. Debaka, you'd like to say? Yes, please, please.
I mean, de-escalation can only occur when we have stabilized the patient, and so by definition, the patient is no more in shock. So shock is unstable phase, just because by definition, the cells are not receiving enough oxygen at that time, and so it cannot be prolonged. So what we may have is a patient who require for prolonged time some vasopressors. It doesn't mean because the patient is treated with vasopressors that you cannot begin to at least de-escalate for fluids if there are some signs that the patient is no more fluid responsive in these conditions. So I think that
would you consider diuretics? My question is, would you consider diuretics then? Patient has a very positive fluid balance and is not fluid responsive now.
Of course, at that time you may consider this because there are no more signs that these fluids are beneficial for this patient. So, and we probably need to get rid of from these fluids. I hope the patient will respond to diuretics. Everything depends on the kidney perfusion and blood pressure and other things like this. So this is the limitation, is a response to diuretics at this stage.
Dr. Govil, what would be your approach in this kind of patient? No longer fluid responsive, positive fluid balance, still on ventilator. I'm sure you'll say I'll do lung ultrasound now. And
no, but that has already been done so many times, so there's nothing new. It depends on what findings are there and what are the cardiac functions. So if we feel that patient is in fluid overload, what, like we have to decide, otherwise the vasopressors is the choice.
So I would just like to end the session now. I would like each of the speakers to just give me one take-home message for hemodynamic monitoring in shock. in COVID-19? Just one take-home message that anything, each one of you could give me one point that we can just integrate and that we should remember, specific to COVID, of course. So, of course, Professor Tabul always comes who wants it first. So, Professor Tabul, from you, one line, just one. What do
we can have many take-home messages because we talk about maybe 3 years for 3 years, 3 hours. Sorry, for 3 hours about this. The first thing I think it is important to use hemodynamic monitoring, not just to use, but to assess the benefit-risk ratio of any intervention and to check after the intervention what we did in terms of benefits and in terms of risk. And this is important to use it for this.
Okay, so always risk benefit.
We have also many other messages.
Yes, no, one, just one. So Professor Shirin.
We don't have another 3 hours, so just one.
Not 3 hours yet, sorry, we have one enough. Professor Shirin, one message, I just want one. So
one message based on my talk, look at your patient. You don't always need expensive monitors to get an information about your patient. Just look at him and assess him clinically.
Professor De Becker.
So shock is an unstable condition, and so it cannot be protracted. You need to rapidly intervene and to try to get rid of the impairment due to hypoperfusion using the interventions that are the most likely to solve it. So you probably need to assess it and to make measurements as needed. And so that's what we have some place for hemodynamic monitoring in these patients.
Right. So don't take shock lightly. Dr. Govil, one message.
So when I was a little younger, 5 years back, I used to do this hemodynamic monitoring to give fluid. And now I realize that this hemodynamic monitoring should be used to restrict fluid as well.
Right. So be careful about the fluid you're giving and perhaps a role for early vasopressors. Dr. Kulkarni?
Assess and reassess and reassess.
Right. So that's very important. It's not one static phase. It's dynamic. So keep reassessing. Dr. Srinivas?
Well, what COVID has taught me is that this is one situation where distributive, obstructive, and cardiogenic shock can happen in the same patient at the same time. So keep your eyes open. You could be overdoing one aspect of resuscitation while it's working detrimental to the other type. This is what COVID has taught me. So that's the message can happen. Obstructive shock can happen while myocarditis and distributive shock are going on. So that's a challenge.
Point. So you could have different types of shock together. So I'd like to thank all the speakers, especially the international and national faculty, really for stretching the time. There have been so many questions and I'm really, really grateful to you. And the reason I've extended this is because it was just so important and this topic is so important and your feedback and your thoughts and your comments and your answers are just so useful to the 2,000 delegates that are logged into this program. So I really appreciate the extra time that you have given to us. I know you're very busy and it's really testing times, especially to the Indian faculty, because they're really busy in the intensive care units at the moment. And thank you to all the delegates for their patient listening. I'm sorry we're not being able to answer all your questions, but I'm sure from the comments of the expert faculty, you've got very good take-home messages. I hand over to Dr. Divatia.
I think it's getting late in the day. We've had an extensive discussion. Thank you for joining this Department of Anesthesia, Critical Care and Pain of the Tata Memorial Center. Sheila has organized this, invited everyone, got the people together. So that was a great thing. And special thanks to all my colleagues in India who are otherwise working very hard. Dr. Deepak Peting was dashing back from the ICU to be with us. And to all our friends from abroad who've actually spent so much time and been very generous with their time and of course their advice and their knowledge. So thank you all for joining us. And let's hope we will win this together. And it's just a matter of time, but let's hold on, let's hang on there, and I'm sure we'll come out victorious. Thank you very much.
Take care and stay safe.